Hello, Mario.
Hi, Murat.
How are you? So
Fine, fine.
happy, so
Yeah,
happy to see you.
yeah,
So it's your session actually. We have
yeah, yeah. It's my presentation now.
we have we have a lot of questions
Okay,
about the kids, the chip kids, and
okay,
you are the expert on that, you know.
okay. I will check everything and try to.
Uh, and
Okay.
I have read in the weekend your new article about IARC
Yeah, yeah,
considerations about the validation of HPV kits. Maybe you will talk about that, right?
yeah. Okay.
Okay, dear friends, after some coffee break, we are back again. Once again, congratulations to everybody, to the ESGO team for this wonderful organization. Now we are starting session three, which is really
Hi,
very,
Murat.
very hot session. Hello, Reda. Hello, welcome.
Hello.
Because you had a lot of questions about the HPV DNA screening programs, and you especially artificial intelligence and also the colposcopy. But first, we will discuss about the HPV kits, the current status, and then we will move towards several different screening strategies in Africa, and end with the artificial intelligence. What is the advantage today to Africa? So the first speaker is one of the pioneers in this respect in the world. The almost all validations and these type of new kits are examined, evaluated by Mario Poljak. He's a very good friend of us and ESGO member also. Welcome, Mario. We will happy to listen the affordable, clinical, validated HPV assays. You know, in Africa, in low middle income countries, we have really financial problems. And what is your suggestion for these validation issues? We are with you, Mario.
Thank you. Thank you very much for kind invitation. It's my pleasure and honor as always. Before I start talking about affordable tests, first a review of the commercial test on the market. So my group, it's making every few years periodical inventories of all. We are counting all commercial tests for HPV which are on the global market. So we did already 5 of such inventories. So I will present the results which actually reflect the situation on the global market in December 2023. So in all these countings, we are counting tests as distinct tests or separate tests or test variants. So for example, if particular HPV test is considered variant if it's technologically identical with a particular distinct test but target different HPV types. For example, here in this case, we count this test as a distinct test and this same test but targeting 2 different genotypes as a test variant. So in December 2023, we can identify at least 264 distinct commercial HPV tests on the global market, plus 511 test variants. So if we are looking who is producing these tests, you see here that almost half of all tests are produced in Asia Pacific region, 1/3 in Europe, and around 20% in North and South America. And on country level, China is producing around 1/3 of all tests. Although Africa has the highest incidence of cervical cancer in the world, there is no single HPV test produced in African land. So when we compare the December 2023 and 2020 January, we only recognize there is not a total number of the tests which was present on the market increased only with for the 10 tests. But you see here that actually in these 4 years, 76 tests actually disappeared from the market and 86 actually are introduced on the market. This means that we have a very high withdrawal and introduction market dynamic in the world. But if more tests actually mean more quality, unfortunately not. So when we look on all details of this test, actually we realize that half of the commercial tests on the market are without a single peer review publication, that not mentioned in any publication. And actually the evidence of quality, either analytical if these are genotyping tests, or clinical if they are tended to clinical use, it's lacking for the 80% of the tests on the market. As we know, only clinically validated HPV tests should be used in cervical cancer screening programs for the clinical management. And together with a group of the Mark Arbin, we are also making periodical counting of the tests which are clinically validated. And this is the last published evidence published in HPV World. You see here that at that time we only had the 19 HPV DNA tests and single HPV messenger RNA tests, which are considered as clinically validated using international cross-sectional validation criteria, and only actually these 20 tests should be used for clinical management. It's even worse if you look on the WHO pre-qualification status, which allow countries to buy, to purchase these reagents. You see that actually in February 2025, this last update I received from WHO, only 4 tests actually were WHO pre-qualified, and the 4 tests were in the process of pre-qualification. Because to reach the elimination of cervical cancer, we need between 1.4 and 1.5 billion tests, and we are far away from this number of the tests in the market. This is why WHO is actually working with the stakeholders to reach this goal. And recently, 2 TTPs, so-called target profile product profiles for HPV test, was published, actually to guide innovations in the HPV testing and also to motivate test developer manufacturers to address global health needs. It's a freely available document, so WHO has a very detailed procedure how to develop the WHO TTPs, and they always look on the different characteristics of the test and actually put so-called minimal or lowest acceptable criteria for every parameter, and also so-called preferred or ideal criteria. So when we actually made this document, we decided to make actually 2 documents: one for the HPV test for the laboratory use, and one for the point of care use. And we actually put 41 different requirements for the future HPV test, which are actually across all main 8 domains, including the cost, as the guidance for the manufacturers. Another push in addition to the TTPs, it's a revolution which occurred in clinical microbiology during the COVID time. So the COVID time actually is a really testament what is possible to achieve quickly when it's required and when funding is available to support innovations. So what actually COVID showed us that we can actually have final push for point of care test. We can go away from PCR if needed. We can recycle long-term neglected technologies, also ideas, and also introduce new innovative technologies, including out-of-the-box ideas. So my own wish for the test for the low-income country should be that this test should work preferably on dry swab, no liquid transport media, minimal or no extraction of DNA, affordable small device, or preferably device-free, or you only using smartphone. They should use isothermal amplification, preferably at room temperature, target at least 8 genotypes, and this is now the preferred by TTPs, and minimal requirements, no cold chain power of water requirements, high analytical specificity, high clinical sensitivity, which is equal to the validated HPV test, should work equally on the clinically collected and self samples, not labor intensive, and using like paper-based or based on similar sustainable material. So I will now show you that in addition to this, however, we all know that affordability is the most significant barrier to global implementation. This is why actually we are asking manufacturers to make as cheaper as possible products, because otherwise we cannot use them in low-income countries. So these are a few elements which I mentioned as my own wish for the future tests. So I really prefer isothermal amplification, and one of the most famous is so-called loop-mediated isothermal amplification. We have one test which fit in this category, which is commercially available, which put also genotypes in the 4 actionable categories according to the ER criteria. Also, the problem with the test, they still need an instrument for reading out the results. They also have a problem with the contamination and with the stability of reagents, but now in this paper this year, they significantly improved the test, actually making very sustainable reagents and also make a very innovative procedure to prevent false positive results. But however, as I said, we maybe would need to go out of the instrument, and this is what was actually developed during the SARS-CoV time, when you can actually, after LAMP, you can read the reaction with the naked eye, just as plus or minus negative results in this single tube or in the 96 well format. Then we can also use after LAMP a traditional lateral flow, which we used a lot during the COVID time. Or we can use more innovative technologies like this one, when the LAMP reaction was actually detected by electrochemical bioassay. There is several other isothermal methods, and one of my favorites is this one. It's called RPA, or recombinase polymerase amplification. Why? The problem with the LAMP is that you need to have some kind of temperature between 40 and 60 degrees. This is why you need the instrument. So here you have a isothermal amplification which work on the room temperature, use 3 different enzymes, and you see here that the first positive results is already visible after 7 minutes. And this is kind of the HPV-based assay, still requiring a small instrument for HPV detection based on RPA, but still you see that, I mean, the sensitivity is very high, as well as specificity here, looking here in across genotyping testing. For detection of the LAMP products, I prefer personally the CRISP-Cas, which is actually a method which was originally developed and first described in 2020, received the Nobel Prize. 8 years before, it was for the first time, 2012, it was for the first time described, but already after 8 years, Emmanuel Champetier and Jennifer Doudna received Nobel Prize for this. It's a method which is initially meant to make a genome editing for therapeutical purposes, but also it's very useful in diagnostic virology. So currently, the majority of tests which are described in the literature use the CRISP detection only as a part of the whole procedure. When you need to still extract something pre-amplified with isothermal amplification, which increase the sensitivity, you use a CRISP as the most specific method available here, and then you need to read out the generated signal. So the first HP paper based on CRISP was already published 2018. You see 6 years after the first description of the method, with a Nobel Prize winner here as the last author. And then there's several papers published on different prototypes of HPV tests using a CRISP-Cas methodology. I just pick a few just to demonstrate you. For example, this one is very nice because after you read out actually signal with a simple ultraviolet light. It's very cheap test. And also this one is very good because we will need, at least in African and at least in HIV positive population, we will need to really make a genotyping for triage. And this is kind of the HPV test which use this special chip in which you can really genotype whatever genotypes you want. I also maybe even use a methylation or something for triage, which is needed. All these tests which I show you actually request some pre-amplification. So this is the first one, amplification-free system. So the system without amplification, detecting HPV 16 and 18 in 20 minutes. This one is from COVID. So I show you this one, which is it's very interesting because here you use actually body temperature to have temperature needed for reaction. So after you mix all reagents, you just put here the tube in the arms here, and then all reaction is actually made by incubation by using body heat. My idea generally is that we need to go away from the instruments, using universal instruments, not specific instruments for the test like a mobile phone or tablets. And even before COVID, we published this review paper of using mobile phone as a mobile microbiological laboratories. So during the COVID, people were very innovative. So this is kind of SARS-CoV test, which was performed in the Lisbon. You see, this is the laboratory here, and actually all tests, it's using an ordinary mobile phone, and actually test, it's this one, which is connected with the mobile phone. This is a sample. And you see here excellent sensitivity and specificity for SARS-CoV, similar to the real-time PCR, 15 minutes sample to results time and 2 minutes heads-on time. And I can imagine such one using same technology for HPV screening. What about going without instrument and without electricity? Here I put all my money on the paper-based microfluidic assay, and you will heard today about some of these prototypes. Because paper has ability to transport fluids through the capillary action, you don't need complicated pumps on other fluid handling equipment. It's low cost, easy to use, responsible and virtual equipment free, and it's also the most ecologically sustainable. So even before COVID, people was very innovative. So this is like a completely paper-based test based for detection of malaria. You see here this part for extraction. And the preparation of the master mix, and this one for the detection here. During the COVID, the prices of reagents go really low. In some cases, you see here that they even produce a paper-based test for the SARS-CoV-2 for $0.3 per test, manufacture production. And this is the one which is still in, if you look on the literature, paper-based test based for detection of DNA, HPV DNA. We still use this small instrument, but the old test actually is the paper-based. And you see here how this look like. So as a highlights or a conclusion, we have 260 plus commercial HPV tests exist on global market, but half of the tests are without a single publication. Published evidence of analytical or clinical performance quality is lacking for 80% of commercial HPV tests. WHO is really working hard with stakeholders to change this unfortunate reality in the global market. This is why actually we published 2 ATTPs recently to guide innovations and motivate test developers, manufacturers to access global health needs. And I really believe that innovative HPV testing concepts which are developed during the COVID diagnostic revolution are now evolving and will hopefully be available on global market soon. And all this knowledge will transfer also to the HPV market. So it's not easy to predict the future, but my opinion or opinion of Yalin Kilic is the best way to predict the future. It's actually to invent it. And I think we have all tools to invent a cheap and affordable test in the near future. Thank you. Murat.
Yeah, thank you so much, dear Mario. There are several questions. I have answered some of them from the chat box.
Okay.
But let's continue where we are, okay? And maybe you can reply to some of
I will
these
reply.
questions,
I will reply
Mario,
now. Yeah,
from
in
the
the
message section.
next
Thank you
minute.
so
Thank
much,
you.
Mario.
Thank you. Thank you.
Wonderful, very promising news. Now the next speakers is now we have a dual speaker actually. Uh, is it real that can we have really cheap HPV DNA kits? Then from the ESGO experts, we produce one PCR kit and started a project in Ghana. Now let's listen, Professor Yalin from Turkey, how we produce this kit and how it costs now, and then what are the preliminary results in Ghana. Mr. Yalin, are you together with us? Yes. First, you talk, please, about the.
I'm Murat. So I was expecting a talk after Nadja, but I don't know like if they prepared my slide. I'm not sure.
Okay, so then Nadja, you can start. Nadja is one of the best ESGO volunteers, dear friends. She makes a foundation funding from some churches from Austria, then ESGO donations, and she started a screening project in Ghana, which is done by this Carci-Scan kit. Nadja, are you okay and available now? We are with you.
Yes, yes, thank you, Murat. Thank you, Yalin. So just see if I have control over my slides.
Well, actually, next slide. Can you make it? Next slide.
Yes, it's perfect. It works.
Okay.
Yes. Thank you. So, hello to you all. Hello, colleagues, to your team. It's an honor to be able to present today our first results and also the study which we performed with the previous mentioned Carci-Scan kit in Ghana. Where did we perform it? If you look at the map, this is Ghana, this is the capital, which is Accra. Near here, you have a cervical cancer screening possibilities because it's just better than in the rural areas. We performed it in Techiman, which is like 1 hour flight to Kumasi and then another 3-hour drive up here. So this is where we performed our study at the Holy Family Hospital in Techiman, Ghana. This is just quickly for you to see how long it took us from the idea to the implementation to the finalizing of the recruitment of the patients. We were on site in July 2023, and then after some training, we started the cervical cancer screening unit in March 2024. After ethics approval and study protocol and everything that was required, including funding, which Murat also mentioned. And then we did the recruitment from April to October 2024. In 6 months, we recruited 1,030 patients on site. The background and the aim of the study, as you all know, and we already discussed today, the WHO recommendations on the elimination of cervical cancer, and they highly recommend the high-performance test, which is HPV-based cervical cancer screening. We also follow the see and treat algorithm, which is recommended by the WHO. So we screen the patients, and if there is like a HPV positive patient with major changes, we do a thermocoagulation with a thermocoagulator, which is already used on site. So we did a pilot study to see the feasibility of cervical cancer screening in this particular area and hospital using HPV self-sampling. Our primary aim was feasibility, and secondary outcomes were obstacles, difficulties, HPV prevalence in the cohort, and other secondary outcomes which were defined preliminary. So if you look at the study design, we did a pilot study, prospective cohort design. We plan to enroll 1,000 patients in the Holy Family Hospital. So it was a hospital-based screening. We also did education on HPV, cervical cancer in general, prevention and screening. And then we trained the midwives and the colleagues on site doing HPV self-sampling and providing it for the patients. And as I said, to get some feasibility and real-world data on the prevalence. The secondary outcomes, which I mentioned earlier, you see here listed, reaching from the prevalence of our HPV positive rate down to dropout rate of the patients, which we included, and also the loss to follow-up rate, which is very important in this cohort. So we included patients from 30 to 65 years old, asymptomatic, non-pregnant, and we did self-sampling with the copan swabs and then ran the Carci-Scan kit, which Yalin will present later on. The positive patients got called in for colposcopy, and all areas that met criteria for HSIL major changes were treated with legal thermocoagulator. They had a clinical checkup after 6 weeks, and then a follow-up with another self-sampling will be undertaken after 6 months, which will be done this September when we do another 2-week visit on site. The HPV negative patients were emphasized to rescreen in 3 years' time and got the information and the paper with the result. The sampling and the analysis. So first we took the sample with the copan floc swab, which you see here. Then we stored it dry and then put it in the medium. As a second step, we did the analysis with the Carci-Scan kit, testing for HPV 16, 18, and 45, and then gave the patients the information for their results. And then in a third step, the ones who were positive were called in for colposcopy. And in the fourth step, there would be a follow-up for the patients after 6 months. Here you see our 2 midwives, 2 of the 3 which we trained for colposcopy in Ghana, Angie and Amma, doing colposcopy. And like I said, we used the legal thermocoagulator, which you can see on the next picture. If you have not already seen how it looks like, this is the device that's already been on site to treat the patients right away. The follow-up will take place this September, and here just to show you how we did the education, this were all the women coming in the morning, and then Amma or Angie, depending on which midwife was there.
7, 8, 9, 10.
explaining in English and also in their native language how to properly use the swab very explicitly, because it was also very important for us to see how many swabs we were not able to analyze. So we did screen in the time where we have been on site in the 2 months, around 300 patients for colposcopy training and also for the self-sampling swabs. We trained 3 midwives, 2 consultants, and all the residents. And then, thanks to Murat, Yalin, and also Alpa, we were able to install the PCR machine on site and opening the unit in March 2024 after 8 weeks of training. And we've finished recruitment in October 2024, gathering 1,013 samples and analyzed them. So as we are preparing the publication now, we have the primary outcomes and the results, which I'm very happy to present today. First question was, is it feasible? Yes, it's feasible to screen a lot of patients in a short amount of time, and when only 1% of the patient would not prefer self-sampling next time. So nearly 100% of them would want to have self-sampling next time compared to provider-taken samples. And looking at the secondary outcomes, the prevalence of high-risk HPV was around 12%, but we have to take in mind that it's a bias because it's a hospital-based screening. We also tested only for 3 types of high-risk HPV. The other secondary outcomes you see here, the dropout and the loss to follow-up rate has to be evaluated after September this year, where we go on site again for the follow-up of the patients. This is just for you to see how it looked like. This is the PCR machine that was set up, Alpa, while training the 2 lab technicians on site. And this was the colposcopy room and our setup, where we did training and examinations every day. The obstacles that we've seen were a couple of them, but I think the most important one, which is also very important if you consider doing training and implementing screening in the low and middle income setting, is the cost. So with an average wage in Ghana from 80 to 120 euros per month, and now offered HPV testing for 21 to 49 euros per person per testing, it's much too high for the people to afford it. So our actual cost now, including all of the infrastructure and the test kits, varies around 13 to 17 euros, but we need to get it down. And Yalin will talk about later on that this kit is especially designed for the low and middle income setting because it's very accurate and also very cheap. So altogether, we have to thank our colleagues at the Holy Family Hospital in Techiman, without whom this project would have not been able at all. They trained at the very high level. They have a very high expertise. Here you see the midwives who are running now the cervical cancer screening unit 5 days per week. And here you see one group of the patients which we included. So I really have to thank all of the people who contributed to this work and to the success of the implementation of HPV-based cervical cancer screening in Techiman, Ghana. And I'm happy to hear about the Carci-Scan kit from Yalin. Thank you so much all for your attention.
Thank you so much, Nadja. It was wonderful to listen. Amazing story what you have done in Ghana on behalf of ESGO. Thank you so much. Now let's listen, Dr. Yalin Kilic, how you prepared this PCR, real-time PCR in a cheap way, and can we help Africa, Yalin?
Yeah, I want to talk more specifically about the problems in implementing the molecular diagnostics approach for cervical cancer screening, and also our in-house developed Carci-Scan kit for the limited budget. If I can control my slides, let me try it again. Oops, there is a lag. Okay, so thinking globally, we are far behind our target of 70% global coverage for cervical cancer screening. Although most African countries are fully committed for the WHO goal, no country-wide screening program in high coverage has been yet performed by 2025. And of course, the main reason is cost. The cost for infrastructure and also cost per test. There's a slight delay, I'm sorry. So By infrastructure, I mean the equipment, laboratory, trained technical personnel, and also the logistic structure for sample collection and patient follow-up. Since it's not generally a point-of-care test that gives immediate results, patients need to be reached after the results have been declared. And the cost per test includes the PCR kit, DNA extraction kit, specimen brush, transport medium, and as well as plastic consumables like filtered pipette tips and reaction vessels. So most molecular diagnostic tests are PCR based, so you will need a PCR equipment. There are cheaper PCR equipment, but selecting a limited specifications equipment may increase the cost per test this time and significantly. Diagnostic laboratories for molecular genetic tests need some properties like separate rooms for pre-PCR and post-PCR and controlled air pressure and laminar airflow. It looks like you can perform it on a biochemistry lab bench, but you will soon start to have the whole test giving positive results. So this is also one other thing to be improved as the infrastructure. And specimens actually worth more than the detection kit itself. At first, it doesn't look like this, but all the laboratories have to archive them for future population studies. Since our aim is not to detect the HPV, but to estimate which patients have a higher risk to have cervical cancer, it's highly important to turn back and analyze the earlier specimens of a cancer patient in the future. And ultra deep freezers or the minus 86 degrees or minus 80 degrees can be found as low as $5,000, and a 5-liter equipment can hold more than 30,000 specimen as single equipment. Molecular diagnostics are slightly different than other biochemistry tests, especially in fitting volumes of very few microliters and also using filtered pipette tips. And contamination term in molecular diagnostics is not by a microorganism, but by DNA that is exponentially amplified during the PCR. There are specific needs to keep the laboratory working properly. Also, these needs another training for the personnel to be recruited. And the infrastructure, the PCR equipment is not most of the time like an autoanalyzer that you simply load the specimen tray and get the test results in a laboratory information system. It needs specific setup and generally a manual analysis step after the reaction finishes. Since it's mostly not a point of care test and laboratory results will come in a few days or weeks, if not longer, a logistic structure is necessary to maintain the specimen transport and patient reach back for positive results. And the cost per test can be as high as $80 per patient. And most of European validated tests are being above $10 and $15. Cost per test needs to be analyzed as not only the PCR assay itself, but also nucleic acid extraction kit, specimen brush, transport medium, single-use plastics like pipette tips, reaction vessels, and else, increasing the cost, sometimes even doubling it. But why these costs are so high and it differs a lot between the brands? So costs for PCR assay depends mostly on the technology. If it's based on real-time PCR or some other diagnostic method like chip-based assays. Cost depends on how automated the system is. If it's as simple as an automated system from sample to result, or it needs a lot of manual processing. Cost also depends on if a separate DNA extraction step is necessary. Some solutions include the nucleic acid extraction as a part of the automated process, and some does not use at all, but it is known that the lower limit of detection may be 2 to 3 logs higher without the DNA extraction step, and then it is increasing false negativity. And brands with European validation have a significantly higher price tag, claiming a better performance in detection. And Like for cost per test, the cost per building up the infrastructure also significantly vary. For some tests, using an automated equipment is mandatory. Automation is helpful, of course, in high throughput laboratories, but some automated equipment may have brand specific consumables that also have bring high prices, up to 10-fold compared to the open platform ones. Non-open platform tests using PCR or non-PCR technologies may have significantly higher prices compared to the open platform ones. On the other hand, open platform ones may have more manual processes compared to the other ones. PCR equipment may have different capacities, like generally accepting 96 reactions to serve more than 90 patients when setting once. This number decreases if multiple steps are applied. And they also have different number of fluorescent channels, a maximum of 5 channels, where the quantum resolution limits it to 5 only. And given the properties of fluorophores used for DNA tagging, one channel is generally reserved for internal control of the test, and more channels means less reactions necessary to cover the same target. So in short, single equipment is generally useless, and instead of 3 separate reactions in a dual channel equipment, a single reaction is enough in a 4-channel equipment. A popular brand of 4-channel real-time equipment price ranges around $25,000 to $35,000 per equipment. And average minimum cost per test is $10, where it needs to go down to $1 to keep in the WHO target of cervical cancer elimination. But is that really possible? So in Carci-Scan, it was possible for us to reach almost these costs, where the cost per PCR test, kit per test was less than $1, and together with other costs, it was about $2. This cost, of course, excludes the labor, the physical examination, or other costs for infrastructure. We manufactured only a few thousand of reactions here, and it's possible to go down to $1, including all the other side costs at number of millions of tests. So how we brought the cost down? To bring the cost down, first, we performed most of the processes manually. Automation increases the cost even when the labor is added in low resource countries. We developed our own PCR assay together with our own nucleic acid extraction assay and our own sample transport medium to bring the cost down. We did not use any ready-to-use reagent buffers or master mixes. We prepared them from components. So we designed it for a 4-channel PCR equipment where only a single reaction tube will be enough for one patient with of course, limited number of targets. Perhaps the most important approach to bring the cost down was limiting the target high-risk HPVs in sacrifice of increasing the false negativity significantly. Among all 13 high-risk types known to cause cervical cancer, we selected only the top 3, disregarding all other only HPV 16, HPV 18, and HPV 45, and nothing else detected at all. So they are the cause for the 77% of the cervical cancer cases in most of the places. Cost of the PCR directly depends on the number of targets. So with a test with 3 targets, it will have at least the cost of 1/3 comparing to targeting 13 of them. But what about the huge 23% of false negativity? This causing to miss an important number of infected patients under cervical cancer. So if your screening budget is limited, everything changes. If you don't have enough budget, the amount of false negativity is not, if you have enough budget, of course, the amount of false negativity is not generally acceptable. But if you do not have it, you are otherwise missing all the patients when not performing the screening at all. So when you perform it with a $1 Carci-Scan test, targeting the 3 most prevalent types of high-risk HPV, you are missing 23% of the patients. Comparingly, if you perform it with a reference test costing 10% and targeting 13 high-risk types, you are only missing 1.5% of the patients. But it's only in the screened population, and since you will be only able to screen 10% of the population compared with other, with the Carci-Scan, you're missing plus 90% of the patients that since they are out of your budget. And if you have a limited budget, using Carci-Scan will significantly save more lives. With a $2 Carci-Scan tests, you are catching 38% of the positive patients. With a $1 Carci-Scan test, you are catching 77% of the patients. With a $10 US test, you are catching only 9.85% of the patients. I'm talking about the $2 kit and $1 kit is the same. It just depends on the volume of the manufacturing. It can go down below $1 very easily. And excuse me, so I have to go one back. And before performing the Holy Family Hospital in Takimangana, we validated the developed assay with the Karolinska Institute HPV Center references to confirm 100% specificity and target type and 0% cross reaction to the other types. We confirmed that this test is capable of catching about a few hundred copies for HPV 16 and HPV 18, and a few thousand copies for HPV 45. And also, we performed a mini clinical study with 400 patients in Hacettepe University, Turkey. Of those, 14 of them were positive, where 5 of them were infections with multiple high-risk types. We compared Carci-Scan results with the CGene results as a validated reference that's used in routine in Hacettepe University. It was highly concordant, only missing one patient with HPV 51. This was the first version of the Carci-Scan where we targeted 13 high-risk types plus HPV 6 and HPV 11 for evaluation of vaccine performance. The $1 US Carci-Scan version now only targets the three types, 16, 18, and 45. But it can be customized very easily to detect other three types if necessary, since we designed and validated all the reagents to work together in the same reagent tube. And Carci-Scan kit is available as non-profit cost for pilot screening studies in Africa. If necessary, we can tailor it to detect other types to serve if a country has specific needs other than 16, 18, and 45. And you can contact ESCO or Dr. Murat Gultekin if you are interested in performing a screening in using a Carci-Scan kit. Thank you very much.
Thank you so much, dear Yalin and Nadia. There are several questions, but we have time limitations, you know. I will be very much happy if you can answer the questions in the Q&A section.
Yes, of course,
or
we'll
in
try.
the conversations.
And they can always reach us by email
Yeah.
later.
There's a really huge interest on the Ghana project results. And also some countries do ask some more collaboration, some technical questions for Carci-Scan. It was really very, very interesting, but please answer some of these questions as a written way so that we can follow. Okay, dears? Both in the Q&A section and also in the dialogue section of the Zoom. So the next speaker is coming from Egypt, Reda. Reda, are you with us? Basel, sorry, Basel. There is a very, very important initiative in Egypt. It's a presidential initiative to eliminate the cervical cancer. And they have done a lot of political meetings. And I hope maybe Cairo will be the first country, Egypt will be the first to eliminate the cervical cancer. Basel, can you inform us how you challenge the minds of your politicians?
I think Basil's presentation is pre-recorded.
Okay.
Yes, I'm here. It is recorded,
Yeah.
so I'm waiting for the recording to work. But because I'm in the airport.
Okay, let's start it so that then we can discuss with Basel in the real life. Yes.
Good afternoon, everyone. It's my pleasure to be with you today in the ESGO Prevention Virtual Conference, the second one about cervical cancer elimination in Africa. And here, it's my pleasure to present about the Presidential Initiative for Cervical Cancer Screening in Egypt and the political impact leverage on screening practice. Here I am presenting on behalf of the Presidential Initiative of Early Cancer Detection and Awareness and Screening, and on behalf of the Egyptian Gynecology Society, being the General Secretary of Egyptian Oncology Society, And on behalf of ISGO, as I am ISGO Council member representing the many European countries. So what was the situation in Egypt? What's the actions and what's the outcomes to know the story so fast? There were no data available about primary prevention. We didn't have enough data about the prevalence of cervical cancer in Egypt. About primary prevention, the HPV vaccination hasn't been introduced in the national immunization program yet. About the secondary prevention, there were no regular screening program against cervical cancer. Now we have, and in the tertiary prevention, now we managed to do the national guidelines on cervical cancer management. There were additional challenges on the level of healthcare providers about the socio-cultural religious challenges, gaps in knowledge even among the healthcare providers about HPV disease burden and even what's HPV, the lack of strong provider recommendation, and the high cost of HPV vaccination and HPV screening. There were additional challenges on the level of the public community, not only the HCPs, but also the public community about the poor awareness of HPV infection, the stigma of HPV being a sexually transmitted disease, and the misconception about HPV vaccination. So there was a great vaccine hesitancy that was really managed. And the most important to speak today about the level of policymakers. So when we spoke to the policymakers about the importance of doing the primary and secondary prevention in the form of vaccination and screening, there were lack of data about burden of HPV disease in Egypt. So this hinders the informed decision making. There was limited resources and competing priorities, especially with the COVID epidemic, the wars all happening all around the region, all the economic instability, and the uncoordinated efforts among different parties, which didn't make great progress towards the goal of cervical cancer elimination. So the actions that started, and here it was the action of many people. One of them is Dr. Mohammed Al-Azab, our partner in the PIC Executive Office, about the data generation, increasing public awareness, medical education, and then all of this goes to political commitments when we found the problem. For the prevalence, there were some published papers, not very strong evidence, but still it's stated that the HPV prevalence in Egypt is around 14.3. And then we started doing public awareness through the social media, through the social influencers, through the TV shows, the radio shows. So we tried to spread awareness and provide the public with accurate information about HPV and cervical cancer, and to promote cervical cancer screening confidence. And then was an important part was medical education, which was supported by Dr. Khalid Abdel Ghaffar, Professor Khalid Abdel Ghaffar, the Minister of Health in Egypt, doing multiple screening campaigns, workshops, conferences, educational events, going around. This was in my center, colposcopy workshops and training the young doctors how to do with that. And then the aim of today's presentation was how to do political commitment. So in 2023, Presidential Initiative was launched to screen against cervical cancer. First phase, June 23, covering 9 governments. Second phase, January 24, covering 9 governments. Third phase in August 24, covered 9 governments, using HPV DNA testing as primary screening test. There was not collaboration only with the Ministry of Health, but again with the Ministry of Social Solidarity to promote cervical cancer screening program, doing some campaigns phased around to go all around Egypt, what we, Mohammed Al-Azab named 1,000 kilometers campaign, going all around and train community leaders to serve as trusted advocates and educators, enabling them to spread accurate information about HPV, promote cervical cancer screening programs. So that was the numbers, with more than 203,000 beneficiaries, 2 million, 2 million, with more than 1,893,700 home visits, and with more than 25,883 seminars. And then a mobile car clinic, which was copied from the mammogram, mobile mammogram clinics that go around Egypt, has been proposed. It's designed to offer screening and vaccination with treatment with a primary focus on raising awareness and reducing burden of cervical cancer, with aim to reach out the public and provide comprehensive care through those mobile car clinics. There were collaboration with dermatologists going to all the big dermatology hospitals to increase the awareness and examine females there. And there were some sort of partnerships with Ministry of Health, Ministry of Social Solidarity, and the Ministry of Education to increase the awareness about HPV disease and value vaccination among students and teachers. And the aim was to vaccinate 30,000 girls aged from 12 to 15 years old. And what was the outcome? We had the National Cervical Cancer Screening Campaign to cover all the 27 governments. So that the structure of presidential initiative, it started a few years ago with the breast initiative, and after a great success that was published in ESMO, presented in ESMO, we had the Presidential Initiative for Cancer Early Detection and Management, which is PICE, covering the three big cancers beside breast, which is lung cancer, colon cancer, prostate cancer, and why cervix? Because this is WHO policy to eliminate cervical cancer, the 90-70-90 policy that has been discussed today many times. So in Egypt, we said, even if we don't have those high prevalence of cervical cancer in Egypt, we should join all the international efforts and the collaborations to eliminate cervical cancer by 2030. So the vision of this campaign was to establish a resilient and inclusive healthcare system in Egypt, where all individuals are empowered with knowledge and access to regular cancer screening and early detection service, leading to significant reduction in cancer incidence, mortality, and contributing to the global effort to eliminate cancer as public health concern. The mission was to enhance the health and well-being of Egyptian population by implementing comprehensive cancer screening and early detection programs, ensuring equitable access to preventive strategies, reducing cancer-related morbidity and mortality in alignment with WHO guidelines, United Nations Sustainable Development Goals. So what were the 8 pillars of this presidential initiative? Early detection, diagnosis, awareness, management and survivorship, data management, training, center of excellence, and research. So what were the objectives? Early detection of cancer in early stage to decrease the mortality rate, reducing late stage patient expenses by early detection, and eradication of cervical cancer in Egypt, the 90-70-90 policy by 23. So what we have done, citizens from 18 years old can fill out a questionnaire. This questionnaire is through 3,538 primary care units, or through not only the primary care unit, but through social media, through the medical convoys, through a hotline, telephone hotline, and then the electronic system will identify the target groups. What's the high risk for lung cancer, for colon, for prostate, for cervix. This is the questionnaire that's filled. It takes less than 5 to 10 minutes to fulfill it. And then, for example, if you are a current smoker, you will be directed to the national program to smoking cessation. If you have high suspicions for lung cancer, the patient go to the care centers to do a CT. If equal 4A, you do further diagnostic investigation, biopsy, pathology testing, and then to manage to the MDT. The colon cancer through FET test. If positive, the patient undergo colonoscopy, or the individual, not the patient yet, the person undergo colonoscopy. If abnormal pathological testing, then MDT. In prostate, using the PSA test and detecting after that and going further. In cervix, we had a vertical females, so all females aged 35 and 45. So those were the peaks of cervical cancer. Do HPV testing, if positive, colposcopy, if abnormal cells, biopsy taking, pathology revision. It was all centralized. Pathology labs, if we find just its precancerous lesion or CIN1, she is presented to her gynecologist for proper management. If we find invasive carcinoma, he is presented to the MDT, and here is the gynecologist and surgical oncologist and the clinical and radiologist all deal with those patients. So more than 6,000 women were screened, and more than 13,000 girls were vaccinated. That was not only the Ministry of Education, but again for the Ministry of Higher Education, for the universities. We went to the universities, we went to the public and raise awareness in the universities, in the public regions, on the TV shows. And this is the mobile clinic, car clinic, as we said. It goes from Cairo, Alexandria, Mansoura, the far north to the far south in Luxor and Aswan, going and increasing awareness for all girls. And then So that was the efforts. The numbers, the final numbers will be published once we have the final results of the number of cervical cancer cases detected and the number of HPV vaccination, everything. I'd like to thank Dr. all the PIC office, Dr. Mohammed Al-Azab, Dr. Fahd Abdulaziz, Dr. Nabin Mustafa, Ramat Hamada, and everyone who shared in that, and hope next year we will find the final results and we will say what we have reached through that, and thank you.
Thank you so much, Bazel, for this nice presentation. Congratulations to Egypt for this great initiative on the cancer. Not only one cancer, and I hope you find the good fundings for all of these 4 cancers. Now, let's continue with the Egypt, but particular interest for cervical cancer. Reda, we are with you, my friend.
Okay. Hello, Murat. Hello, all my colleagues. I will congratulate ESGO Prevention again for this excellent second Africa cervical cancer elimination webinar. Is it working? So, yes, it's okay. It's working. I have nothing to declare. I would like to thank all members of ESGO Prevention for the excellent webinar organization. As you know, I will skip these slides because I already mentioned in previous presentations. As you know, this is a worldwide burden of cervical cancer. Unfortunately, 85% of worldwide deaths come from our low resource setting countries, especially in Africa. As you see, this is a world map of cervical cancer mortality, mostly in sub-Saharan African countries. The mortality in cervical cancer in low-income countries 18 times more than the world. So to eliminate cervical cancer also in Africa, you should adopt the WHO 2030 strategy of vaccination, screening, and treatment. However, there is certain obstacles in our African countries that may interfere with implementation of the WHO strategy. What are these conflicts and how to overcome them using the available resources? As you know, the gross domestic product per person in Africa is only $2,900, while all over the world it's $13,800. Also, according to 2022 exchange rate, the average monthly pay for African person is only $758, while it is in USA and England is 7,900 and $7,700. So it is the salary in Africa is much low. We must put this in consideration when we plan for any preventive protocol. This example of the some African salary, monthly salary, as you know, is very low in comparing with USA and UK. Also, furthermore, other African problems exist also related to poor housing, poor traffic, security, and poor education. More than half of African citizens don't have access to health care, unfortunately. Of course, this may make the quality of health services are poor. Furthermore, most of African countries has no national health insurance coverage, no national HPV vaccination strategy, except 3 to 4 countries, as my colleagues previously mentioned, no national screening programs, as Professor Mark Arben has mentioned, poor health care infrastructures, and also there is deficient radiotherapy machines and chemotherapy services in many of our African countries. So in this situation, as I mentioned before, with poor economy, poor infrastructure in many African countries, but we still can do something to eradicate cervical cancer. As this photo, don't look only to the bad half of the picture. You can also have a hope and look to the fruitful green side of the picture. So how we can do in our in this situation with using our available resources? First, regarding vaccination, the vaccine in Egypt cost $32, which actually is too much regarding the low salary in Egypt and many African countries. What we did in our Mansoura Gynecologic Oncology Unit in our local initiative, we make a partnership with non-governmental organization, the Rotary Club Egypt, Professor Amal Sisi. This cooperation supplied us with the large thousand of vaccine doses who given to girls below 20 years. I also remember that my professor Orlich as early morning mentioned that please look for a partner to help you in implementation of your program. So we give the dose for free for girls, and if they can offer the second dose on their own expects well and good. If they can't, we still also refer to the WHO strategy or WHO policy 2022 that only one vaccine dose is enough. Regarding secondary prevention, the available method of cervical cancer screening, as my colleagues has mentioned in the morning, HPV DNA is the most accurate, most accepted worldwide, but for African countries, it's expensive. Second is cytology, and also need infrastructure and they need trained cytologists. The third one that we use in our gynae oncology unit in Mansoura is visual inspection with acetic acid and also Lugol's iodine, which is simple, sensitive, low cost, but still full specificity. However, it's suitable for African countries which have low resources. Via test, it also obey or has all criteria of WHO screening for ideal screening test, being cheap, available, sensitive, acceptable, not need training, can be done by doctors and also paramedicals. So it's excellent for training for African countries. Publications from WHO and also studies from Egypt and India has also reported that the sensitivity of VIA test is more or less, if not more than cytology. However, specificity is slightly less than Pap smear. For good sensitivity but less specificity for VIA test, I advise my African colleagues if they don't have HPV DNA, don't have cytology, please use this simple test until the resources are good. Then you can use your more accurate tests. Also, for my advice to gynecology units in Africa, please try to train gynecologists in a free training courses so that you will raise their awareness, their experience to pick up cases. Also, in our gynecology unit, we visited villages and the cities to make healthy education and also to make screening in the villages and cities who have not access to visit the central gynecology unit. For result of our 2-year initiative, we screened 6,000 women in the village and cities around Mansoura, 1,200 cases, and we performed 550 biopsies after colposcopy. We diagnosed 105 pre-invasive lesions as well as 18 cervical invasive cancers. So the positive predictive value of VIA test was 22.4%, slightly low, of course, but keep in mind that it is better than nothing. Diagnosed cases were treated after MDT according to international guidelines. The treatment this treatment available. Also, you can use modified leap, which is very cheap. We have a special presentation about modified leap in session 5. I ask all of you to attend this great session. We published our experience in doing cervical cancer elimination in our locality in the International Journal Gynae Cancer last month, and we reported the details of our experience so can be also repeated in other African countries until resources improve and the more accurate tests are available. My advice again to my dear colleagues, especially from Africa, that please don't wait for your governmental support. Do your cervical cancer elimination steps using your available resources. HPV can be used in collaboration with national non-governmental organizations. You should train gynecologists to pick up CIN cases only by doing via tests in their clinics in villages and cities. Also, you can treat high-grade squamous intraepithelial lesion using the cheap available modified leap. Again, thank you my colleagues in the ESGO Prevention Committee for the excellent organization. Thank you, Susanna. Thank you, Murat. And goodbye.
Thank you so much. Thank you so much, Reda. Wonderful and very timely presentation. And the messages was very clear. We will definitely see every year, annually, what's going on in Egypt. And we wish the best success for Africa and for Cairo to the whole team. Let's go to the next speaker. We talk about some PCR kits that you use some device, but on the other hand, we can have some potential paper tests. So Andreas Kaufmann has developed such a kit in Germany. And Andreas, it's pleasure for me to invite you to get the microphone. Andreas?
Thank you, Murat. Thank you, everyone, to being here and taking the task on to help prevent unnecessary dying in Africa from cervical cancer. These are my potential conflict of interest. I have given talks for companies. I was an advisor, but most importantly, I'm inventor in a patent that my university has patented. So these are the potential conflict of interests. And this is the title, oncoprotein tests that are paper-based at the point of care. So this is a very restrictive title already, and I will talk mainly on one test that we have own experiences with in studies in Africa. And before I go into that, I would like to look at the basis of using oncoprotein as a target of testing. The E6 and E7 oncoproteins are expressed after HPV infection in the epithelium at a very low level. This is a strategy of the virus to escape, to evade the immune recognition and induce a long-lasting infection. But at some point during the transformation process, E6, E7 protein, RNA and protein expression is upregulated. And this leads then to high amounts of oncogene in the tissue that can be detected. Our diagnostics we use now, cytology, will detect patients who have dysplasia, because that's the principle of altered cells to detect. DNA detection comes much earlier with even detecting probably deposit of HPV from the last intercourse. RNA detection is more specific because the cell has to be actively transcribing the viral genome. And the oncogene and oncoprotein tests here, they are latest in becoming positive during progression. And this is something that is important to understand, that we will exclude lesions and dysplasia that do not express a high amount of oncoprotein. So cytology for Africa is too laborious to implement, I guess. There is no structure established. The DNA detection is sometimes too sensitive. I come to this in a minute. RNA detection is too expensive mainly, and the oncoprotein tests may be just right because they will be the tests that detect high-grade dysplasia and invasive cancer probably. So importantly, prognostic markers, progression markers would be important to have to further classify women who need treatment from those who will spontaneous regression. So this is a problem that is often overlooked and also by WHO not really respected. This is the prevalence of HPV infection in different areas of the world. In Europe, in the US, in the Americas, the prevalence is around 5 to 10% in the screening age population. However, in Oceania and in African countries, the prevalence in the screening population is much higher. Now, all the studies that have shown efficacy of HPV-based screening were done in the northern countries. We have done some studies in Africa in different countries, in Ghana, Ethiopia, in Uganda, and in Tanzania, and we really find that high HPV prevalence in the screening population, not even HIV positive patients who have 50 to 80% prevalence. I tell this and I stress this because these HPV-based tests might have a problem in the screening when you go into these populations because they just overburden the healthcare system, the follow-up, and the therapeutic system. So what can we do? We can not do HPV testing or reduce the assay sensitivity or reduce the number of HPV types that we test for, but this will miss precancers and cancers, and this will lead to loss of lives. Adding biomarkers might be a solution to that, and the biomarkers we have chosen here is E6 as a viral biomarker. Now, this is a comparison of different testing principles, and I only want to stress here the lateral flow. And in comparison to these very high sensitive tests, they also come with high specificity for HPV infection, not necessarily for dysplasia detection, because the specificity for dysplasia detection is often way lower than for the HPV infection. So in comparison, the oncoprotein tests will have a high specificity because we need high expression of the oncoprotein to be detected in a lateral flow assay. Now, the sensitivity seems to be very questionable or low. And this is again another point I want to stress and explain why this is something that we have to buy in when we use an oncoprotein-based lateral flow assay. Again, a list of different now paper-based assays. I will only talk about the oncoprotein E6 test because the other tests have other targets and are not that suitable for use in as point of care tests and in Africa. So this list is more for you later to study if you want to have the slides. So the paper-based HPV oncoprotein test I'm talking about is produced and developed by Apovita, a California company that tried to develop a test that really is adapted to the low-income situation in the global south. And the biomarker, as I said, is the E6 oncoprotein that is detected, protein is detected by a lateral flow strip that has until now antibodies, capture antibodies coated for detecting HPV 16 E6 or HPV 18 E6. So one disadvantage is we do not cover more HPV types, but these are the HPV types that cause 70% of cervical cancers, 50% of CIN3 lesions, and focus the resources with the least effort to the most efficacy in screening. So it's a simple lateral flow immunoassay. We all know these type of assays since the COVID pandemic. It detects only 16, 18, and 5 initial HPV types are now in development on a separate strip. About 80 samples can be processed in a 3-hour procedure by one technician. So it's a medium throughput test. The specificity is very high because, yes, there needs to be a high-grade dysplasia to make this test become positive and have enough E6 protein expressed. Sensitivity in several studies is between 53–57% to detect CN3. And here, often there is a misunderstanding that we lose a lot of dysplasia that is progressing. And what still has to be shown, but I think it's plausible, that we will miss those CN3 lesions that are not progressors to cancer. Not all CN3 ever will progress to cancer, and those that have low oncogene expression will not be detected in this test. Important is the high positive value. 40% of those who test CN3 or OncoE6 positive really have a CN3 in the end. And also the negative predictive value is good. As I said, this was developed especially for low resource settings, and for that, the instrumentation is kept very simple, transportable, and robust. There's no cold chain necessary for the reagents. The sampling type is a dry swab that can be transported from the sampling site to the lab, or it can be used directly on site. Self-sampling is possible, and it is a test that can quickly be trained in about 1 hour time. So again, this diagram here, again, I show 50% CN3 are progressors, but what happens to the other 50%? These other 50% do not express a high amount of oncoprotein E6, so they will go undetected by the test potentially, while those that are progressors express high amounts of oncoprotein and will become detectable. So do we really want to detect deposit all infections in SYN1 when we have a very limited capacity for treatment? Or do we want to concentrate on those lesions that really need treatment because these are the true progressors to cancer? And this is what in my opinion, the oncoprotein E6 test has an advantage for African countries. Yeah, it has a high sensitivity and specificity for and accuracy for progressive CN3s, and might be a prognostic marker for those women who maybe not be treated because the test is negative. This is a comparison of the OncoE6 results in blue with hybrid capture 2 PCR tests in green over the different stages of dysplasia. And what you can see, of course, and what we expect and what we have trained our HPV tests for is to detect all infections with HPV, making the numbers of patients positive high in SYN1, high in SYN2. And we want, of course, to detect all SYN3 that needs to be treated. Now the OncoE6 test in blue lags behind. And this is, I'm coming to this in a minute, this is reducing the follow-up of those women who are HPV positive versus OncoE6 positive a lot. And imagine what this numbers of reduction does to the follow-up of the healthcare systems in low-income countries where there is restricted capacity. Now let's look at the negative for pathology, but still they are HPV infected or OncoE6 positive. So there are few positives for OncoE6, and in the next slide, this is depicted. The green ones, all dots represent a woman with a high-risk HPV positive result, but in the upper part, they are E6 oncoprotein negative. After 1 year, retesting these women and looking for dysplasia, 1.8% of these women have developed SCN2 and 0.54% had developed SCN3. Now, in contrast, those that are HPV positive but also E6 protein and oncoprotein E6 test positive have different numbers. They have 10 times more SCN2 and 30 times more SCN3 developed. So this means the risk after 12 or 5 years is way higher when the OncoE6 protein test is positive. Of course, then it's a more progressed lesion already and a lesion on the way to becoming a cervical cancer probe. So we can estimate that the OncoE6 expression, the oncoprotein E6 expression, is a prognostic biomarker. It's a viral biomarker. Now, how about implementation of such a test in real life? In Ethiopia, there is the first initiative to produce the OncoE6 kit in the country in a joint venture. And these produced tests then are assembled and distributed and will depend on reimbursement, of course, by the Ministry of Health and the guideline recommendation. They are used at the screening test level. So in a region, this is the Amhara region in the northwest of the country, in 217 facilities, the tests were distributed, the lab technicians were trained for performing the test. And self-sampling was self-sampling and provider-taking samples were tested. The literacy of the care providers for the OncoE6 result was trained. And now, importantly, there is a monitoring by medics to see how many positive negative results are obtained, if there's treatment and loss to follow up, and how many tests are used at all. Cost of the OncoE6 test is right now borne by the implementation by the Ministry of Health. Then this program gets expanded from the Amhara region to different labs, first from the manufacturing labs to other cities, and the it's Bahir Dar Cancer Center, and meanwhile 300,000 tests have been distributed in the region. Obstacles that are reported is currently, oh, this is wrong. I learned yesterday that the production has been started again. Health facilities ask for financial support because there are additional working hours needed. So this cost has to be borne by someone. Time to result is not really too long because the women receive it the same day, but the technicians would like to have an automation. All these women who get tested, they also have a VIA when OncoE6 is used as a confirmatory test. However, it seems that too few women accept testing, and this is due to a not very comprehensive counseling, what it means to get tested. Unfortunately, this has to be improved. And until now, the MOH and the guideline has not yet fully recommended the test. So, what are the results so far? And this was published in PLOS ONE just in the last month. The diagnostic performance in a cross-sectional study that was hospital-based for sampling, the gynecology unit, women who came with any complaints were invited, and every third woman was then recruited to have like random sampling. 297 samples were obtained, some were excluded. This was then compared to the result of VIA screening of the HPV genotyping cervical pap cytology that was study-based, and OncoE6 sample, of course, biopsy and histopathology was taken where indicated and reviewed by 2 pathologists that were blinded to the other results. The performance characteristics of the OncoE6 test were as follows. So specificity is very high to exclude women who have no dysplasia. As before, the sensitivity is at 57%. Now, we have to remind ourselves that this test only detects HPV 16 and 18. And what was looked at here was a histopathology for all potential dysplasia. So actually, 57% positivity rate for HPV 16, 18 in positive histopathology is what we would expect in this situation, just to interpret the data right. So now these outcomes were compared with histopathology and with the pap test that was done. Question is, how many women after these screening tests have to be referred for colposcopy? Because this is the future bottleneck when we roll out screening in countries with a low capacity. So for the histopathology result of SIN2+, there were 56 right positive histologies found after a former VIA or during VIA biopsy. There were no false positives because this was a gold standard, but 5 false negative if we would take the OncoE6 test as the second test that finds dysplasia or prospective dysplasia. So 56 women had to be referred to colposcopy. In comparison, the cytology, pap cytology, found 53 right positive, 6 false positive, 9 false negative. 59 women had to be referred to colposcopy. And the OncoE6 test with the positives in the histology positive and the presumably false positives in the SIN2 negative were 37 right positive and 42 had to be referred to colposcopy, which is about 30% less than vice pap cytology. Again, 16-18 is only measured, so we might miss cases with other HPV types. Caveat to this publication is there is no report on the VIA positivity and the genotyping results, which would be very important.
Andreas, can we a little bit wrap up?
Yes, I wrap up. Comparison of HPV testing with sensitivity that we pushed very high to 95%. The specificity, however, is lower. The oncomarker, the viral biomarker OncoE6, gives a much higher specificity, which will, in the end, save resources in the healthcare system. And I wanted to talk also about this test that also includes cellular biomarkers. I will skip this now, but in future, we will have tests that can even detect not only there is a risk for dysplasia, but there is a certain type of dysplasia, because in African countries, pathology services are scarce. I skip the next slides, but you can come back to me if you want to know more about that. And in summary, the OncoE6 test is a paper-based oncoprotein test that is quite well characterized by many studies and now is being implemented. Cost efficacy is to be determined, as well as clinical efficacy in the real-life situation. It only detects HPV 16, 18, but 5 more types are in development, and it outperforms the PCR testing in specificity, which might be undervalued for the African countries. And what I didn't show is a comprehensive molecular test that overcomes other hurdles in screening, meaning giving a comprehensive result that will reduce follow-up cases a lot in the situation where there is no capacity. I thank you for your attention.
Thank you so much, Andreas. Was really interesting for many African countries. I have answered lots of questions, but there's one question that I will ask you to go to the Q&A section. Now let's go to Democratic Congo, another ESGO volunteers projects. We are really so proud with Luis Shiva, and listen what's going on in Democratic Congo about this project. Gabriel Reina is with us. Gabriel.
Thank you very much, Murat. Thank you very much, let's go for this kind of invitation. We're very happy to be able to share with you our experience in the Democratic Republic of Congo within this project, which is called Elikia, which means hope in Lingala in the local language. So I want to share with you our experience through 3 different sections in my talk. Let me see if I can change the slide. Okay, so I will talk very quick because I think that several speakers have already talked about the importance of this disease around sub-Saharan Africa, but in particular I talk something about the Democratic Republic of the Congo. I will talk later on about the self-testing strategy that we started to implement 2 years ago. And finally, I will discuss about the cost-effective strategy that is something that we are discussing also very much today. So first, I want to go deeper into the data of the Democratic Republic of Congo on cervical cancer. So we already know, and we have already discussed about the importance of the disease in low and middle-income countries, multiplying the incidence, for example, if we compare with Spain, by 6 to 7 times, making this disease the first women's cancer in the country, in the Democratic Republic of the Congo, with around 6 to 7,000 cases each year. So within the strategy of the WHO of screening 70% of women at 35 and 45, we know that in the country we are very far from these figures. So we started in 2007 this Elikia, this HOPE project led by Dr. Chiba, by doing summer campaigns with a group of medical students. So we have performed 8 different campaigns, and we will go in 2 weeks' time. We will be there again for a new one. And the big change this last year has been that a local team has been trained, and they have continued with the local cervical cancer screening since we left Kinshasa last summer. But we have already screened more than 4,000 women in Kinshasa. And I will explain you now how we have done through different steps that we have done. So at the beginning, we performed the screening by visual inspection in the first years, and we could complete the study by doing cytology and HPV detection in Spain. By doing this, we could validate a sustainable screening method by visual inspection in the country, which was the works, another work of characterization by sequencing of HPV-16 from Kinshasa, which were part of the PhD work of Dr. Tendobi, the gynecologist of the hospital where we work in Kinshasa. So after the COVID-19 pandemics, we came back to the country by doing a campaign of more than 1,000 women in 2 weeks, and by implementing the thermal ablation by first time there, and also getting dried blood spots to carry out sexually transmitted infections screening also from the blood. So after starting with our work there, we started to ask ourselves if self-testing was possible in this area, because we know that it can be a very efficient way to carry out the screening. So we prepare our first protocol to explain the way to get the self sampling from women, and with a lot of material, our enthusiastic students and the devices necessary to carry out the HPV DNA locally, we started to do it in 2023, comparing the HPV method with the PCR method from the COVAS 4800 method from Roche, and comparing the self-collected samples with the cervical samples obtained by medical doctors. And from this data, we could analyze the data and see that the self sampling was as valid as the cervical collected samples by clinician, with around 90% of sensitivity and an accuracy around 90% also, if we compare the self-sampling with the clinician collected samples using the PCR method. So once we get to know that self-sampling is valid in our women also, we wanted to decrease the cost, because as we have discussed already this morning, there are perfect HPV screening tests based on a lot of characteristics like the ones I highlight here. But we are very concerned about the cost, and we need a low-cost strategy, a cost-effective strategy. So what we have done to get this, we have started to work using a pooling strategy. So using the self-collected samples in 2024 and doing it locally, we compare the work, the HPV detection by the GeneXpert point-of-care method and the Roche method. So doing the pooling method, that, as you may know, is a way to save money when you are doing PCRs by combining multiple samples into a single test. So we had to mix samples from different women to do a single PCR, so that if a single PCR is negative, we consider the 4 women, for example, negative, following this example with 4 women. If we get a positive pool PCR, we have to perform individual PCRs. This is a method that is able to reduce the cost and to reduce the turnaround time to get the results. So we validated it by checking samples that we took in our campaign 2023 and using the Roche machine, and comparing the data that we got from the PCR with the detection of precancerous lesions through cytology, and doing it with three samples from 3 women per test. We compared the work individual PCR with the pooling strategy by doing 105 pools. And our results with the Roche system was that the clinical performance of this strategy reached almost an 80% of sensitivity of clinical performance when we compare data with the results of precancerous lesions, which was higher than that obtained with individual analysis. The individual PCR, which was almost 70% of sensitivity. We had a problem. We are not going to discuss it now because it will take longer of loss to follow up women. So we consider that a point-of-care method would be also very useful in the field. So we wanted to know what happened with the pooling strategy using the GeneXpert matching, which is able to give you an HPV results in 1 hour. So we perform also a validation of this pooling strategy with these samples that we carried them back to Spain, And we got this result that there was 100% concordance of pooling and individual HPV DNA detection for precancerous lesions. So we were very happy with the results, and we started to perform it in the field. So last year, we performed it in the field, and we presented this in the last conference in February. The sample pooling for HPV DNA screening as a cost-effective strategy in low resource settings. We got an 84% of sensitivity of clinical performance, comparing to the 77% of individual analysis to detect precancerous lesions. So we could say that pooling strategy has an excellent clinical performance for cervical cancer screening, even better than individual analysis. However, we know that the pooling strategy is normally a winning strategy. We can save money, we can save time, but the problem can come with a high prevalence. There are previous works that talks about the high prevalence scenario, which makes difficult to get an economical and operational benefit with this pooling strategy. So what's the situation in the field in the hospital of Mancola in Kinshasa? Well, the situation last year in 2024 was that we had a huge HPV prevalence of 28%. Okay, so within this situation, with this situation of a high HPV prevalence, is pooling a cost-effective strategy. Well, we consider that even in this situation, we can say that yes, it's cost-effective. How can we do it? Well, we are doing this pooling strategy, or we are working in a high HPV prevalence scenario, analyzing 5 targets and analyzing the CT information. I show you here an example of a pooling strategy of 3 samples: 394, 395, 397, positive for other HPV different from 16, 18, 45. In particular, positive for the P25 target with a CT of 29.5. So systematically, we perform the first and the second individual samples for HPV DNA. So for 394, we get a positive signal of 27.2 in the CT, negative the second one. So we can deduct that the third one is a negative sample. Not always it's possible to do this, and sometimes we have to repeat also the third sample. But by taking this strategy and validating it previously in the lab with samples done individually, we have been able to save up to 23% of the cost of the HPV DNA method. Okay, so my final slide is just to give my take-home messages that cervical cancer screening is a health priority in the DRC, where early detection of high-risk HPV is essential to reduce mortality. HPV DNA testing is the preferred method for cervical cancer screening and can be reliably performed on self-collected samples in the DRC, increasing access and participation. Sample pooling, we consider this a promising strategy to lower screening costs by 20 to 30%, making large-scale programs more feasible in low-resource settings, but further research is needed to validate the diagnostic accuracy and reproducibility of HPV pooling approaches in high prevalence and low capacity contexts. And I just want to finish with this sentence that summarizes very well I think the work we are doing, that many small people in small places doing small things can change the world, which is a phrase that Dr. Chiva always reminds us. He's the leader of this project with Dr. Chendobi in the local field. And I just want to thank all the local team there, my enthusiastic PhD students, and all the students and all the people who is supporting us also through the foundation, the NGO, which supports also with a donation. So this is my email in case you want to contact me for any further information. And thank you very much.
Thank you so much, Gabriel. Really was very interesting for me. I learned the strategy of pooling. That really makes the things cheaper for us, for Africa. It was my also pleasure to be in touch with you with the Carci-Scan kit. Yalin has also a lot of interest on your pooling strategy. Maybe we will contact with you with
Yeah.
Yalin. Okay, it's really
Thank you,
nice
Murat.
idea. Nice idea. Okay, so a few questions exist actually on the dialogue section and also in the Q&A section, Gabriel. Maybe you can write some answers and text, to those attendees. I want to now move to our next speaker from Belgium, Nina Dolander. It's also, important, dear friends, the colposcopy. We use this as a triage sometimes in the low middle income countries, directly colposcopy. And it's my pleasure to listen her now and about the latest evidence on these issues.
Thank you, Murat, and thank you, Esko, for inviting me for giving this presentation.
Hello, Nina. Welcome.
Hi, can you hear me?
Very well. We can hear you very
Okay,
well.
perfect.
Lights are on stage.
Okay, so my name is Nina. I work at Cienzano, the Public Health Institute of Belgium, and my background is in biostatistics. Now let's see if I can change these slides. Perfect. So here's the program of the day. So the topic of this presentation is colposcopy as a triage tool for HPV-positive patients, which I conducted a systematic review and meta-analysis in collaboration with my colleagues at Cienzano, in particular with Mark Arbein and Victoria Niaga. We also received a lot of support from other people, so I want to give a quick shout out to Remila Rizake from the Cancer Hospital in Urumqi, China, and to Maribel Albonto from the WHO. So what we'll be covering in this presentation, I will give a quick background on why we were asking questions that led to this systematic review and how we translated them into our research objectives and our PICOs. Then we will quickly cover the results from the search process and the study characteristics of the included studies before we really look at the test performance of colposcopy, and we will discuss some key findings. A quick disclaimer that we are preparing these results for submission, so please consider them as confidential. So here you can see the funders of this project. So for some background, most of you will be familiar with the WHO guidelines on cervical cancer screening, which recommends HPV DNA detection for primary screening, followed either by a screen and treat approach, where all HPV positive patients are treated, or by a screen triage and treat approach, where all HPV positive patients receive a triage test, which will determine who needs treatment, who needs closer follow-up, who can return to regular screening. And suggested triage tests by the WHO are cytology, dual stain cytology, partial genotyping, visual inspection with acetic acid, or colposcopy. Now, most of us know colposcopy as a tool mostly used in disease confirmation, where we'll use colposcopy to look at the cervix. A biopsy will be taken, sent to the lab, and the clinician will wait for a histology result before deciding on what the next action should be. But then for this review, we're really looking at colposcopy as a tool for triage, where it's the colposcopic impression that will be used immediately to make decisions on what the next, what the best next action is. And then the advantage of this approach would be in some settings where it's difficult to recall patients back to the clinic. If you can give immediate feedback, you can also immediately start treatment if that's necessary. And then while the WHO guidelines, they already had a lot of study data to base their guidelines on, but there was actually not yet a published systematic review which evaluated the diagnostic accuracy of colposcopy, specifically in the setting of triaging HPV positive patients. So that's where our review comes in. We follow the PRISMA guidelines, and you can also find their protocol with Prospero if you look up this registry number. The main objective of the systematic review was to evaluate the diagnostic accuracy of colposcopy to triage HPV-positive patients in primary cervical cancer screening. And then we also wanted to compare the diagnostic accuracy with that of cytology in this context. So here are our PICOs. We really wanted to look at the general population participating in cervical cancer screening who had a positive HPV DNA test result. Our index test is obviously colposcopy, but we made a differentiation between the colposcopic impression of low-grade lesions or worse, and the colposcopic impression of high-grade lesions. When studies reported cytology data, we would also extract this so we could compare colposcopy with cytology test performance. Our main outcomes of interest were the sensitivity and specificity to detect SIN2+ or Century+, And the eligible study designs were randomized trials, complete diagnostic studies, and incomplete diagnostic studies with comprehensive follow-up, which I will talk a bit more about later. So now we'll quickly go over the search and selection process. We looked at PubMed, Embase, the Cochrane Register, and Scopus. After excluding duplicate records, well, most records were excluded because they were duplicates, or they were excluded based on the title or abstract. And there were 89 reports that we screened the full text, and we ended up including 11 studies. Now, an interesting remark here is that almost half of the studies we included, we only managed to access the data through contact with the authors. And actually, the most common reason for exclusion during the full text screening was not that the study was not eligible, but simply that the relevant data for review is not available in the publication, and that we also didn't manage to receive it after contacting the authors. That's, yeah, from the perspective of this review, that's really a shame that there's a lot of studies where obviously colposcopy is part of the disease confirmation, but the colposcopy outcomes are not actually linked to the histological outcomes, and we cannot include them in this review. And now next, here you see an overview of the adjusted Quadras checklist, which evaluates the risk of bias for several domains of the included studies. So we look at the target population, the index test, comparator test, reference test, and then the general flow and timing of the study. And you see that most included studies generally score pretty well in most domains. The more problematic domains for this review was the presence of incorporation bias, where you see that in some studies, patients with normal colposcopy are automatically considered free of disease, which is of course a problem when you're trying to evaluate colposcopy. And then we also had issues with differential verification, where patients with normal colposcopy or with abnormal colposcopy would have a different kind of follow-up or a different reference test. Some patients with normal colposcopy do not always have the histological assessment, but might have a different kind of follow-up or a different kind of reference test. So we discussed with the more clinical experts involved in the review, and we separated the studies in two big groups. The first one we consider to be at low risk of bias, and these are studies where either all HPV positive patients had histological assessments, or the HPV positive patients with normal colposcopy had a follow-up visit that we considered to be reliable enough to be of equivalent quality. And then we ended up with 8 studies at low risk of bias, but there were unfortunately also 3 studies which we really had to consider at high risk of bias, where patients with normal colposcopy were very poorly followed up. Yeah, there was just a lot of loss to follow up, or there was no reference test foreseen in the study design. Now, because these studies at high risk of bias, we were discussing what is the best way to handle them. There is still some valuable information in these studies, especially because this kind of bias mostly affects sensitivity, but not so much specificity. So what you'll see in the meta-analysis part is that we include all of the studies in the forest plot, but we provide separate pooled estimates for the studies at low risk of bias. And this way, all of the information is available to you, but we still have like clean, uncontaminated estimates based on the low risk studies. So here we start with the forest plots. This is a forest plot of the diagnostic accuracy of colposcopy, specifically for the colposcopic impression of low-grade lesions or worse to identify SIN2+ cases. And on the left, you see the sensitivity. On the right, you see the specificity. And then the top part of the graph are studies at low risk of bias. And here we see a sensitivity of around 84%, meaning that 84% of SIN2+ cases could be identified using colposcopy triage. And we see a pooled specificity of around 64%, meaning that of the patients who were free of disease, about 64% had a normal colposcopy. Next, I want to show you the forest plot for the relative accuracy, if the slides will change. There we go. So this is the relative accuracy of colposcopy compared to cytology at cutoff ASCUS. On the left, you see the relative sensitivity. On the right, you see the relative specificity. If the estimate is on the right of the black line, this means colposcopy performs better than cytology. If the estimate is on the left of the black line, this means colposcopy performs worse than cytology. And again, the top of the graph are the studies at low risk of bias. And when we look at the pooled relative sensitivity, there is a value of 1.74, and the confidence interval does not include 1. So this indicates colposcopy is more sensitive than cytology. While on the relative specificity, we have a pooled estimate of 0.67, indicating that colposcopy is less specific than cytology. Now, quite typical of diagnostic accuracy studies is that there is quite a lot of heterogeneity in the results. And here we also see quite different values for the estimates. However, what's important to realize is even though these studies are conducted in very different settings, with only one exception, colposcopy is always reported as being as sensitive or more sensitive than cytology. So in this higher level, the results are actually quite consistent. Now, when we will publish the results, we will hope to be able to expand on these results more and create some more intuition. We will also calculate predictive values and such. But here I will just briefly mention that based on our calculations, colposcopy would have a lower predictive value than cytology, but a better negative predictive value. So now let's discuss some of the key findings. Like I mentioned, studies consistently report similar or better sensitivity for colposcopy triage compared to cytology triage. And that's regardless of the very different regions the studies are conducted in. And there's some difference in the study population, differences in age groups, in the background risk of cervical cancer, in the background prevalence of HIV. Some studies are working with self-samples, some studies are working with clinician-based samples. There's so many different settings, and still we have this very consistent conclusion that colposcopy performs similar or better than cytology triage. However, this is accompanied by a decrease in specificity. So in other words, colposcopy triage finds at least as many cases of cervical precancer than cytology triage, but might lead to overdiagnosis and eventually to overtreatment. Then some results I didn't show in the slides, but there were also some indications that the cytology results of the studies included were more heterogeneous. So both of the tests involve some subjectivity, but cytology seemed more prone to the subjectivity. Then to reiterate some of the limitations of this review, a lot of diagnostic studies don't report on their colposcopy outcomes or don't link them to the histology outcomes, but we try to mitigate this by reaching out to the authors, and by being in contact with authors, we actually managed to include data for 5 additional studies. And then another limitation, which I already mentioned, is that not all patients with normal colposcopy always have a histology outcome or another appropriate reference standard. And we try to accommodate for this by stratifying the analysis on the risk of bias. So we have like the cleaner pooled estimates based on the studies at low risk of bias. So then finally, overall, the findings of this review support the WHO guidelines on cervical cancer screening. And in practice in the field, of course, the triage test that is most appropriate will depend on many different factors. And this review is merely just focusing on the test performance. But when we look at test performance, colposcopy can be an acceptable alternative to cytology triage. And we think it would be particularly suited in settings where the recall of patients back to the clinic is quite difficult. And then, of course, we hope to continue our work on this project. And in the future, we hope to look also at the use of portable colposcopy devices and AI-assisted interpretation, which could really benefit mobile clinics. And we also want to look more at the combination of point of care HPV tests and colposcopy. So really, the entire cervical cancer screening process could be done quite quickly, and we can give really quick feedback to the patients. And we also want to look at the combination of colposcopy triage with HPV genotyping to optimize the triage performance even further. So finally, I want to thank all of my collaborators. And you can see my contact details here on the screen. So if you have any more questions in the future, or if you know of any studies with relevant data that we could include, you're very free to welcome me. You're very welcome to contact me. And yeah, thanks again, Murat and Esko, for organizing this conference, and all of you for attending, of course.
Thank you so much, really, Nina. It's a wonderful study with Mark Arbin. I'm also proud to be a part of this meta-analysis, this work. We have a few minutes, maybe one question to you. from Patrick Paddington from Civis 7. Thank you, Nina. A possible bias for colposcopy performance is that knowledge of cytology by the colposcopists affects the performance of colposcopy. Is it increasing the performance, sensitivity, and specificity of colposcopy? Do you think that there is a bias knowing the result of the pap smear before the colposcopy?
For this review, it was difficult to assess the influence of the blinding of the colposcopies because a lot of the studies were not reporting on it. So it's logical, it will have an impact, but in this review, we were not able to look at it into more detail, unfortunately.
Yeah. Thank you so much, Nina. I think it supports WHO and many African countries. If there are more questions, please do not hesitate to ask to us. Now we are moving to our next speaker from Senegal, Mohamed Izzet Sharfi. Mohamed, are you with us? Mohamed
Yes,
is a very important Cervical project in the West Africa. And let's see what's going on in the West Africa about the cervical precancerous lesions screening. Mohamed, we are with you.
thank you, Murat, and thank you, Zesgo, for inviting me for presenting this project. So today I will present the results of the first phase of the CERCOA project. It's a study focused on the prevalence of cervical precancerous lesion and the mapping of HPV carriage in Senegal. This work is a part of broader effort for the prevention and control of cervical cancer, a disease that remains a major public health issue. Through this study, we want to better understand the circulation of HPV, the main risk factor for this cancer, and to identify the most vulnerable populations in order to optimize screening and care strategies.
Just
Sorry.
click in the slide. Yeah.
I'd like to start with this number, 3,542 euro. This is the average direct medical cost a woman must bear for cervical cancer treatment over a period of just a few months. This number alone illustrates the enormous economic burden this disease represents for patients and their families, especially considering that the minimum wage in Senegal is about 90 euro. Beyond this financial cost, we must also consider the physical, psychological, and social consequences that weigh on this woman. Cervical cancer represents a major public health challenge, particularly in Africa. It ranks as the most common cancer in terms of incidence in 21 countries worldwide, 20 of which then are in Africa. This situation is largely explained by the high prevalence of HPV, the primary risk factor of this cancer. In sub-Saharan Africa, around 24% of women are carriers of HPV, highlighting the urgent need for early screening and management to prevent progression to precancerous and cancerous lesions. Despite the major impact of cervical cancer in Africa, few national studies have accurately described the prevalence and distribution of HPV infection in Senegal. The limited available studies, however, highlight a significant circulation of the virus. One study in Senegal, in a sample of 943 women, 22% were HPV positive, and among them, 79% had a high-risk HPV. Another study from Bruni et al. Showed that 24% of women in sub-Saharan Africa were HPV positive despite having a normal pap smear, emphasizing the need for closer monitoring. Another study in Mali, among 82 cases of cervical cancer, 96% were linked to HPV infection, confirming its key role in the development of the disease. This data confirms the urgent need to strengthen research and gain a more comprehensive understanding of the situation. This phase of the Cervical project constitutes one of the first national studies aimed at providing precise data on HPV infection and precancerous cervical lesion in Senegal. Using a representative sample of the female population, this study has the following objectives: to determine the prevalence of HPV infection in Senegal, to establish the diet mapping of the virus distribution across the country, to assess the prevalence of precancerous lesion among women infected with HPV. These data are essential to adapt screening, prevention, and management strategies, thereby strengthening the fight against cervical cancer. This study is cross-sectional study allowing us to assess HPV prevalence at a single point in time, providing a snapshot of the situation within the Senegalese population. As the study aimed to provide representative results, we selected a diverse population covering a variety of demographic and geographic profiles. This ensures a faithful representation of the situation at the national level in both urban and rural settings. The main inclusion criteria were non-pregnant women of childbearing age having begun their sexual activity. To conduct this study, rigorous analyses were performed. For HPV, we first tested for the presence of 19 high-risk HPV and 9 low-risk HPV. The analysis was performed using multiplex PCR. Additional genetic analyses were performed to confirm and specify the viral subtypes present in the participant. For cytology, smears were performed on liquid-based samples. The slides were reread to confirm precancerous lesion and ensure the reliability of the results. This combined analysis allows us to develop an accurate profile of HPV infection and lesions status. A total of 2,302 women were recruited to participate in this study. However, after a process of verification and confirmation of the inclusion criteria, 2,211 women were finally included in the study. The theoretical study population was 2,002 women, representing an inclusion rate of 110%. This percentage reflects the additional effort made to ensure adequate coverage and robust results. This increase is due to strong mobilization and high participation. We will now detail the specific results related to the prevalence HPV and precancerous lesion. Regarding the use of intimate aging products, 21% of the women reported using them. The average age of menopause was 48 years old. Concerning male partner circumcision, 98% of the women stated that their partner was circumcised. Behavior related to smoking and alcohol consumption are relatively low. The HPV status of the participant was known for 62% of them, among whom 1.5% were HIV positive. Regarding cancer history, a few women reported a personal history of cancer, while 7% reported a first-degree family history of cancer. Finally, HPV vaccination was only reported in only 7 participants. Among the women included in the study, HPV positivity was observed in 27.9% of participants. Regarding high-risk HPV, 21.89% of women were carriers of these HPV types, representing 78% of HPV positive women. Furthermore, co-infection with multiple HPV types were identified in 11% of women, representing 40% of HPV positive women. These results demonstrate significant viral circulation, particularly of high-risk HPV, which is a key factor in the development of precancerous lesion and cervical cancer. HPV subtypes were classified based on their oncogenic risk, with low risk shown in yellow in this figure and high risk in red. Type 42, which is in a low risk HPV, ranked first overall. However, among the high risk HPV subtypes, type 52 was the most prevalent, making it the most frequent high risk HPV identified in this study. Types 16 and 18, which are among the most well known for their association with cervical cancer, ranked third and eighth, respectively, in the top 10 HPV types identified in our study. This distribution provides an overview of the circulation of HPV subtypes in Senegal and highlights the importance of monitoring high-risk subtypes. An important observation is that 5 of the 9 HPV types targeted by vaccination appears in the top 10 HPV types identified in this study. This highlights the importance of vaccination against the specific types, as it could potentially reduce the incidence of HPV infection and consequently precancerous and cervical cancer. These findings demonstrate that vaccination is a key strategy in preventing HPV infection, particularly those caused by the most common and oncogenic subtypes such as 16, 18, and 52. Regarding high-risk HPV, although some regions show a lower overall HPV positivity, the same regions display high rates of high-risk HPV, with 6 regions from 14 exceeding the national average. This suggests that even in areas where the overall prevalence of HPV appears lower, high-risk types of the virus are still present at concerning levels. This findings highlights the importance of specific and targeted follow-up in these regions to prevent the risk associated with oncogenic HPV types, which can lead to precancerous lesion and eventually cervical cancer. Regarding high-risk HPV types, a significant interregional variability was observed. Although type 16 and 18 are among the most common nationwide, they are the leading types in only 5 regions in Senegal. This indicates that depending on the region, certain high-risk HPV types predominates over others. Regarding the pathological cytology results, we observe that nearly half of the cases show no abnormalities, which means that a large portion of the population appears to have no significant lesion in the time of screening. However, the other half present with low-grade lesion, indicating a possible progression to higher-grade lesion or spontaneous regression. High-grade lesions remain a minority, but they are still concerning due to their potential to develop into invasive cancer if not properly treated. Regarding the regional prevalence of abnormal pap smears, we observe a cluster in the western part of the country, including this concentration of pathological cases in the West highlights the need for special attention in this area to better understand the regional factors that may influence these results. The distribution of HPV types in Senegal appears to be different to European countries, which may have implications for vaccine efficacy. Women with cytological abnormalities are now invited to colposcopy for further assessment. Only a small proportion of high-risk HPV-positive women had high-grade cervical lesion. Ongoing studies will assess a point-of-care HPV testing for use in mobile screen and treat programs and DNA methylation testing as a triage tool for HPV-positive women detected at screening. Additionally, we will assess differences in cervical cancer genetic susceptibility in West African population compared with other ethnicities to better inform future prevention, screening, and follow-up efforts in West Africa, where cervical cancer mortality remains unacceptably high. And in the end, I would like to express my deepest gratitude to all the patients who generously agreed to participate in this study. Their trust and contribution have been invaluable to our work. I also want to thank every member of our dedicated team who traveled thousands of kilometers across the country in such a short period to make this project a reality. I'm sincerely grateful to the Institut Pasteur of Dakar for its support and strong institutional backing through this research. Finally, I would like to acknowledge all the funders who have supported and continue to support our work. I am proud to say that we are currently collaborating with Imperial College of London, and we have received future funding to advance the development of epigenetic and HPV point-of-care testing. And thank you very much.
Thank you so much, dear Mohammed. It was really very interesting project, and we are so excited to listen. There are several questions, but we can discuss afterwards, you know. But please stay with us. I'm so happy today through Zoom. Many of the countries have communication, networking with each other. That's why we are here actually, to create this network among the African countries and also Europe. So let's go to our next speaker, which is Silvia de San Jose from Spain. Silvia is one of actually my mentor. Please listen her very carefully. She is the brain of the world in the AI. Silvia, we are with you.
Thank you very much, Murat. It's a pleasure to be here with you and all the participants for a second time in a row. Very nice to have these successful meetings, and I appreciate that you asked me a question that I think it's important for everybody trying to plan new activities. And we are in the era of the artificial intelligence, and sometimes we can see clearly that incorporation of AI can really make our life easier and simpler. But is this going to save money in screening in low and middle income countries? This is what I'm going to try to develop. The whole presentation I have been discussing with my colleague Nicole Campos, who is a modeler and a decision scientist that is helping us in developing all the cost effectiveness results or evaluation in many of the settings where we are working now. So I thank her as well for her help. See if I can move. No, it doesn't. No, sorry, I have to go back. Can I go back?
Should I assist you?
Yeah, I wanted to go to the previous slide, please.
Oh,
So
okay, click.
Yeah, the next one, please.
Yeah, just click on the presentation and now you are good to go. Yeah.
Yeah, okay, thank you. So there are many aspects that we need to take into account when we are trying to really do interventions to prevent cervical cancer in Africa. And here is a list. I'm not going to go over that, but one of the important ones, which I put it here in red, is limited access to screening services. I click on, yeah. Oh no, can you go back to, can you assist me, please? I don't know why it doesn't move with hard drive.
There is a 3-second delay, Silvia, when you make next.
Okay.
Okay.
Silvia, maybe it's better than you use your page up, page down, or something like that.
Yes, what I'm trying.
Yeah, it's much better than anything else.
But just wait 3 seconds.
Yeah, but just wait. There is a 1 sec delay.
Okay. I'll try to do it 3 seconds. If not, sorry about that. So the important message is that many regions in Africa lack sufficient healthcare infrastructure and resources for widespread screening, cervical cancer screening programs. That is clear for all of us that we are in this conference. This results in a significant portion of women not being screened for cervical cancer, and therefore leading to diagnosis at later stage, poor survival in many of the low resource settings. I leave the 3 seconds. Okay. So the effect on that, just in a graphic way, is that we have a high burden of disease, like you can see in big red on the left-hand side of sub-Saharan African countries. We are all aware of this, and this is why we are here. Unfortunately, when we measure the coverage of screening in these countries, in the whole continent, in the whole region, we are seeing that the big red, not the strong red, representing that less than 10% of the women living today and that are from the ages that they should be targeted with the screening activity have not had the chances to be screened. And as well, on the right-hand side, there is a map that tried to identify what were the screening tools being used in Africa. And you can see in green represents VIA, blue is cytology, very little HPV testing, and VIA, you know, it's not the very best performing screening approach. We should try to improve that, and WHO recommends to use HPV testing instead of VIA. So that's our problem, how we can transition to a better screening. Okay, 3 seconds. In this graphic, which I have shown several times, I show it because I think it really indicates what is happening in the world according to the resources available, and this is a demographic pyramid of four regions of the world. The left-hand side are the rich countries, and the right-hand side are the low, mainly sub-Saharan countries. And the bars represent the volume of women that have been screened or not screened. If it's blue, is that they have been screened. If it's in red, is that they have not been screened. This is, I think the indicator was never screened, so 0 screening ever. You can see that the volume of women with no screening it's more relevant for lower and middle income countries. This representing as well Brazil, China, India. In sub-Saharan Africa, the volume of the population is lower, but the blue line practically doesn't exist. So we have to understand that we have to do a big job before we can move it to the graphic colors of the high-income countries. Okay. So the idea is, can we use artificial intelligence approach to do the job? And when we talk about artificial intelligence, we mean to look at the cervix and to see whether the cervix has something abnormal. Using artificial intelligence would not require, if used on its own, an important skills of knowledge as gynecologists and colposcopists they have. So in theory, that could really simplify the work. I want to make 2 considerations. One is that if we use automatic visual evaluation, some groups are working on that as a primary screening. For us, it represents that we will have critical issues in expanding and improving coverage, and as well, it may not perform as well as we would like to have it, because it's an image evaluation, and the variability of images that we can obtain in the cervix are very large and very important. So for us to go to the upper part, not that to use AI as an automatic visual evaluation as a primary screening tool, we think it's not the most appropriate. It will require a speculum exam for all women. So with limited provider capacity settings, this is going to be a problem. We are working on the use of artificial intelligence as a triage test and following after HPV self-sampling, because this is likely to be a very cost-effective approach. Just by using self-sampling and HPV test, it means that we are only going to have to examine physically those women that they are HPV positive. In some settings will be 30%, in HIV population maybe 40%, in some lower risk areas maybe 14-15%. So we really get reassured that a large part of the population that do not need to have a clinical exam. It's important to understand we work with the concept that HPV status provides a very important risk stratification. It's very unlikely that someone has a cervical cancer disease if it's HPV negative. And speculum examination is only, I repeat, limited to HPV positive women. So we are working on the PAVE project. This is a project that aims to be cost effective. We are working on these models, and you will hear more from my colleague Didam Egemen afterwards. The project, it includes the HPV testing, self-sampling. Then we use extended genotype because we want to stratify as much as possible the risk for a woman to have a CIN3. And here we always work with CIN3 plus, because we think that that is the most replicability and consensus outcome. CIN2, I heard the previous speakers that they talk about CIN2. We have a lot of problems in trying to replicate CIN2 diagnosis. So, and then when we have a woman with the HPV test, we submit those that they are positive to a cervical image, and we run an AI algorithm to identify the diagnosis and the risk level. So let's move now to the cost, because Didam will explain a bit more about this project. What we see is that the most relevant cost of a validated strategy implies to buy the HPV test, the self-sampling devices, managing the lesions, ablation, lip surgery. So ablation will be cheaper, obviously. If you need to have a big surgery, it's going to cost a lot of money. We have to think about the workforce, so the health workers, lab technicians, program administration and training, very important, the training part. We have to have campaigns, outreach and education. We have to have a patient navigation approaches with cell phone use, SMS, transportation assistance. We need software updates for the AI solution, so we need the hardware, which is a very small cost, but it's likely that once we have the model, we have now one, we will have to keep on improving that and making it more updated. So finally, what is important is to balance all these costs and see what is happening with our population. So is AI then likely to save money? Clearly, no. If you don't have any screening structure, no screening, no money is spent. So more money you are going to save if you do nothing. But if no infrastructure is available for a complete screening ground, there are no cost offsets from preventing cancers. So ineffective screening, like with low sensitive, incomplete follow-up, incomplete treatment, not treating the totality of the women that need to be treated, is not an efficient use of your limited funds. So if you do it, if you start, you have to establish and organize screening that will require yes investment. So treatment of precancers is less costly than treating a cancer, and this is going to be in your balance to see what do you prefer and what do you can afford. What is important is how many lives you are able to save with your strategy with a given money. So prevention, and we are fond prevention can provide a high value for the money. So while AI and the PAVE strategy or any effective screening program are going to cost you money, like you will have to build this infrastructure to deliver the interventions to the patients, we anticipate that effective interventions, even if costly, can provide a high value for money. The efficiency and value of these programs, cost per year of life saved, for example, is a good indicator, or cost per cancer or death averted, is likely to be much greater than what it is currently in place. Here I show you a graphic. I hope you can see it well. This is a graph from Sims colleagues from Sims et al. From Australia, where they have done the evaluation of many strategies. This has been published, and the red arrow on the left is doing nothing, no screening. Obviously, you don't save life, but you don't have any cost. All the strategies that use HPV test, the red arrow on the left, are on the line in mauve, in green, in blue. You can model the intervals between screens, how do you triage, what is the ages you start. All the models that use HPV test, an HPV test that has been properly validated, are cost effective. So that is what is important. When you decide your intervention, you can decide the most, let's say, the less costly, but all of them, if you are using HPV test, this is going to be cost effective. You see the strategies that use only VIA or cytology are not cost effective in low resource settings, and these models were generated taking into account 75 countries that they are low and middle income countries. So in summary, in low income settings, investment for a screening intervention to reach high coverage may be high to build infrastructure that does not yet exist. The return on this investment is likely to be substantial if a screening intervention can be targeted and effective. In settings with minimal screening, the greatest benefit is achieved following the first lifetime screening, where you really get all the prevalent disease and you can act in a large number of women. Reaching all women of optimal screening age, starting 25 or 30, depends on the HIV context, and finishing at 49 years old, for at least one accurate screening round should be a high priority in public health planning. So if you cannot do 2 rounds, do 1, but do it well. AI can increase screening accuracy and efficiency by targeting women at the highest risk, and Didan will show you more on that. And with this, I thank you for your attention.
Thank you so much, my dear Sylvia. Once again, was very, very exciting presentation. Really, everybody can help also Sylvia's project with some colposcopy gallery pictures. Don't forget, AI is something that is always continuous training. So with your pathology reports and with your high quality colposcopy pictures, you can join the project of Sylvia. Sylvia, there were several probably questions, but let's continue with the program now, and we can discuss some at the end of the session. If available, I would like to ask Didem Egemen here. Didem is also worked a lot with Sylvia in US. You know, United States has changed their screening guidelines to a risk-based screening guideline based on previous history of vaccination screening stories. And I wonder really, Didem, can we make a similar one for African countries? We are poor, don't forget. Huh? Don't ask me the 5 year, 10 years ago history, but give us some a short summary for what we can do for Africa. Maybe not all ladies, but high risk ladies. I don't know. We are waiting and listening, Didem.
Thank you so much, Murat, for this nice introduction. And that's exactly what I will talk about today. So I'll just set the ground with what we did in the US setting for the risk-based guidelines and how we can achieve this similar approach in developing in low resource settings, actually with the strategy that Sylvia presented as our PAVE strategy. I'm a statistician at the US National Cancer Institute. And I've been working on risk-based guidelines for a long while. So let's start. I hope we don't have any lag in the slides. Okay, no disclosures. And so yeah, initially I will start with the US guidelines, how we developed risk-based guidelines, and how we can achieve that in low resource settings, especially with the PAVE strategy combining HPV extended genotyping and a visual screening test. So during screening, what is our aim? We're aiming to detect precancers that are most likely to invade into cancer. That's why for the risk calculations, we always focus on CIN3 or worse status, the likelihood of having a CIN3 or worse situation. Not CIN2, to obtain more robust results. But before, what is the risk-based approach to management? It is not much different than what the clinicians actually implement in their clinical settings. So they collect some specific inputs, which are markers. It can be age of patient, HPV status, even genotype, cytology, and they try to create an output with this input. What can these outputs be? These are the management options. It can be as simple as, should I screen or not screen? Should I treat or not treat? Or it can be as complicated as the options that we have in the US. But with the risk-based approach, what we do is we take all these inputs, put them in a risk model, and obtain absolute risks of individuals. And through some management thresholds, we define which risk groups need which type of management. And with this approach in the US, we were able to incorporate the past history of the individuals as an input rather than only looking at the current results. And we know that if a patient has a positive HPV positivity in their past, their risk is increasing, but if they have an HPV negative in their past, within 5 years, their risk is quite lower. And now we also in the US, we were able to easily incorporate new screening tests into the guidelines, dual stain extended genotyping, because now we don't have to have like the guidelines committee like getting together extensively. We are calculating the risks, and we have a small enduring guidelines committee who approves these new guidelines for these new strategies. And we also need to assess the portability, because when we estimate these risks, it's from one sample from this population. So we also assessed whether these absolute risks are applicable to the whole US population. So this figure summarizes the risk-based guidelines in the US that we have. So first, it starts with looking at current CIN3 plus risk. If I look at a patient, what is their risk, today's risk of having a CIN3 or worse situation? If that risk is above 4%, 4% is actually a low threshold, but that was the threshold that our clinicians, our expert group, accepted for the US. And how we translate these risks into management is through these management thresholds, as you can see in this graph. So we define these thresholds through our consensus group. I did calculations on benefits and harms, and by considering those calculations, these are the intervals that our clinicians feel safest for their patients. So if the risk is above 4%, that means they need a management today, either colposcopy or an immediate treatment. But if today's risk is less than 4%, we look at their long-term risk, 5-year risk. And we defined the safest time interval to rescreen these individuals, either 1 year, 3 year, or 5 year. So how can we achieve a similar approach in a low resource setting, especially with the strategy that I will present here, our PACE strategy? It all starts with a self-sampling, HPV self-sampling. If they are HPV negative, they're reassured. But for the HPV positive individuals, the screening test that we use gives the 13 types in 4 hierarchical channels, as you can see here. And as a triage test, we have an AI-based visual evaluation. The AI algorithm evaluates the cervix image to give one of the 3 test results: normal, indeterminate, or severe. That indeterminate can be considered as an equivocal result, like ASPIS in cytology. And our aim is, by combining these 2 biomarkers, to create the risk profile of the population so that we know which group needs most attention, highest risk, high, medium, and low, and if there is a follow-up capacity, who can come back for a follow-up. So now I will show you our pilot result from our PACE strategy. We conducted this study in 9 countries, including South America, Africa, and East Asia. And so this was our external validation result, because our AI algorithm is trained on other studies, and now this is our external validation. So if we look at the HPV positive population, their precancer risk is 7.2%. If we only, sorry, I proceed back. Okay. So if we only look at HPV test results, we can see a fine risk stratification ranging from 3% all the way to 19%. And if we only look at the visual test result, we can see a good risk stratification ranging from 5% to 13%. But the finest risk stratification is obtained when we combine these 2 biomarkers. The highest risk is obtained when the individual has 16 positivity with the worst looking cervix. Their risk is 27% and they need some management today. And then we have high group, the medium group, and low group. The risk in the low group goes as low as to 1%. And these are individuals with the least risky type, infected with least risky types, and normal looking cervix. And so by using this strategy, how can we develop risk-based guidelines? So to help these regions, I created this concentration curve, and this will inform the healthcare decision makers to decide on where to put their thresholds. That also depends on like how many thresholds they can have. Is the only option treat or not treat? Do they have follow-up capacity? So based on these different options, different decisions, this curve can inform the healthcare decision makers on where to put the thresholds, like in the US guidelines setting. So this curve shows the whole population on the x-axis, 0% all the way to 100%, and the population is ranked from highest risk to lowest risk. So these color codes are matching with the table I showed you before. We start with the highest risk group, and the y-axis shows the cumulative percent of precancer cancer cases that are expected in this population. So it starts with the highest risk group, 16 positive AV severe. If we only treat this group, we will be treating 1.5% of the population, and in return, we will be eliminating 19% of the expected precancers. And then if we go up one level up, we will be, if this is a cut point, then we would be treating the 3.4% of the whole population, And in return, in total, the 33% of the precancers will be eliminated. So let's say we put a threshold at the end of the red boxes, then the meaning, the implication will be 8.9% of the population will be treated, and in return, 65% of precancer cancer cases will be eliminated, treated. We can go as high as up to this end of these yellow dots here. And that means like everyone, let's say if this is a treatment cut point and everyone falling into all these categories will be treated, and we will be treating 23% of the whole population. And in return, we will be eliminating 96% of the precancer cancer cases. So depending on the treatment capacity, depending on the available resources, each country can define their own thresholds and based on available management options. It can be only treat, not treat, treat with some follow-up capacity. So this curve will help the countries define where to put the treatment thresholds and obtain their risk-based guidelines. And all the clinicians in that setting will follow these guidelines. So to summarize, like in low resource settings, there's already, the resources are already low, and we need to direct these resources to the highest risk patients to maximize the utility of screening. So what will the risk-based guidelines provide? It will help defining the highest risk or high risk group of patients who need the treatment most. And also it will provide an objective management decision. Once the treatment cut points or the management cut points are set, all of the clinicians will follow these guidelines and everyone in this population will receive the same management. So thank you so much. This is the end of my talk. We cannot hear you, Murat. You're muted.
Really? I just checked you if you
Yes.
can, translate from an unvoiced
Lip sync.
lip movements. Yeah. So the people are really very excited, and there were several actually good questions. But one of them is, do you really believe that can we make a pilot project in any African countries that's volunteer for you?
Actually, we already did with our PAVE strategy. We
Yes.
we worked with 9 countries.
Yes.
But in that project, we didn't implement our AI algorithm. We were just testing the algorithm without showing the clinicians. And in our next phase of the project, we will actually test the effectiveness of the AI algorithm. And we can also implement this risk-based guidelines. We can provide them these concentration curves, and they can define their own cut points where they feel safest for their patients.
Thank you so much, Didem. The last speaker of this session now comes from Senegal, Omer. Omer, are you here?
Thank you, Murat. I'm here.
Thank you so much. Omer is also doing a lot of colposcopy jobs. He's Secretary General of Senegal, colposcopy conference, and we will listen a little bit about what are the difficulties they face in resource-limited countries. Omer, Gassama is with you.
Thank you, Murad. Thank you, ESCO Prevention Committee team, and Susanna for your remarkable work. I will do my speech in French. J'ai pas de conflit d'intérêt.
Yeah.
En parlant de l'épidémiologie du
So,
cancer.
Omer, I want to inform the people that Omer will make the presentation in French, and you can follow from the translation Zoom that you can the technical people has already shared the link, so you can just click on that and listen in English or any other language you prefer. Yes, Omer, let's start again.
Thank you, Murat. Sur le plan épidémiologique, nous savons que le cancer du col de l'utérus, comme on l'a dit depuis ce matin, ça constitue un véritable problème de santé publique parce que dans le monde, il y a plus de 600 000 nouveaux cas, il y a plus de 350 000 femmes qui meurent. C'est le deuxième cancer de la femme en Afrique, évidemment. C'est le cancer de la femme jeune, c'est le cancer le plus mortel. Et ça survient habituellement dans les pays de l'Afrique subsaharienne. En Afrique, chaque année, il y a plus de 118 000 nouveaux cas, il y a plus de 76 000 décès, il y a avec une mortalité de 64,55%, ce qui pose un problème de prise en charge par le diagnostic habituellement tardif en Afrique. Au Sénégal, chaque année, il y a plus de 2064 nouveaux cas, il y a plus de 1300 décès. La mortalité est également lourde avec 64,29%. Et pourtant, l'histoire naturelle du cancer du col de l'utérus, c'est l'une des histoires naturelles les mieux connues. Et pourtant, chaque 2 minutes, une femme meurt de cancer du col. C'est une véritable tragédie. C'est une véritable tragédie parce que nous connaissons la cause. C'est un cancer qui a un rapport avec le papillomavirus. Ça a été prouvé par Zaral Zorusen d'abord en 1972 et c'est en 1996 que l'Organisation mondiale de la santé a classé le papillomavirus comme cause de cancer du col de l'utérus. Dans beaucoup de pays africains, ce sont surtout les papillomavirus 16 et 18 qui sont les plus fréquemment retrouvés, comme celui a été montré par beaucoup d'études, par une étude multicentrique qui a été faite au Cameroun, au Gabon, à Madagascar, en Côte d'Ivoire et au Sénégal. Vous voyez que tout simplement, ce sont les papillomavirus 16 et 18 qui sont les plus prédominants. C'est une histoire d'amour qui a mal tourné, qui met en jeu un homme, une femme et un papillomavirus qui se sont peut-être rencontrés par hasard et qui s'est prolongé sur un riz. Et malheureusement, la fille va être contaminée. Une fois que la fille est contaminée, dans 70% des cas, les lésions vont régresser, mais sous l'influence de facteurs viraux tels que la charge virale, tels que le type de virus, la persistance du virus, la protéine P53, la protéine du rétinoblastome et HIV, mais les facteurs environnementaux et alimentaires, les facteurs gynécologiques obstétricaux, mais également la perturbation du microbiote, ça va évoluer vers une CIN1. La lésion va régresser dans 43% des cas, ça peut évoluer vers une CIN2+. Et enfin, dans 12% des cas, ça peut évoluer vers un cancer invasif du corps. Comme nous l'avons dit, l'Afrique présente des chiffres alarmants parce que tout simplement, le cancer du col de l'utérus tue beaucoup de femmes dans des pays à ressources limitées comme ceux de l'Afrique subsaharienne. Ceci est lié surtout à des difficultés du dépistage. Ces difficultés sont en rapport avec l'ignorance d'abord. Les décideurs politiques qui ne sont pas conscients de la gravité et de l'importance de dépister les femmes, mais également les prestataires de santé qui ne maîtrisent pas les algorithmes de dépistage humain, les techniques de dépistage, mais également les clients également qui ne savent pas en cas de lésion précancéreuse, là il faut aller consulter. En plus de l'ignorance, nous notons également le déficit en ressources humaines. Ces ressources humaines sont insuffisantes, surtout les gynécologues obstétriciens, les sages-femmes, les infirmiers, les secrétaires également, mais également les agents administratifs. Le cancer du col de l'utérus tue encore parce qu'en plus de ces deux facteurs, il y a le déficit en hôpital, le déficit en centre de santé, le déficit en poste de santé et le déficit également en case de santé aussi. Il y a un problème également du point de vue équipement et consommant. Il y a les ruptures sont fréquentes en acide acétique, en Lugol également, l'absence d'ionothérapie, l'absence d'anse thermique pour traiter les lésions précancéreuses, l'insuffisance ou l'absence de colposcope qui doit permettre de confirmer le diagnostic en cas de lésions précancéreuses. Devant ces difficultés, il était urgent de trouver des solutions. Nous proposons les solutions suivantes. Il faut former d'abord les prestataires de santé. Il faudra faire également la promotion en faisant de l'information, de l'éducation, de la communication auprès des décideurs, auprès des prestataires, auprès également des clients et de la communauté pour qu'ils puissent savoir la gravité du cancer du col de l'utérus, pour qu'ils puissent également prendre les mesures de précaution idoines. Il faudra évidemment sensibiliser les décideurs pour favoriser la construction d'infrastructures, l'équipement des infrastructures, mais également, surtout, il faut avoir un programme national de dépistage du cancer du col de l'utérus qui est calqué sur les recommandations de l'Organisation mondiale de la santé, qui fait la promotion du test viral HPV lorsqu'il est disponible. Il faudra disséminer le programme national de dépistage. Il faut former les prestataires de santé, former les secrétaires pour le suivi, sensibiliser les communautés, avoir également une base de données pour pouvoir suivre les patients et voir également la performance, faire un contrôle qualité régulièrement. Au Sénégal, voilà l'algorithme de dépistage qui est proposé. Ça repose sur l'inspection visuelle après application d'acide acétique dans les zones les plus reculées du pays, c'est-à-dire en zone rurale. Après le poste de santé, dans un centre de santé en zone urbaine, si le test viral HPV est disponible, c'est ce test viral HPV qu'il faudra préconiser. En cas d'anomalie, recourir à la colposcopie. Une fois qu'on fait l'inspection visuelle après application d'acide acétique, si c'est positif et que la patiente est éligible au traitement, il faut la traiter. Si elle n'est pas éligible, il faudra leur faire une colonisation à l'os déterminée. Nous avons dit la formation des prestataires est extrêmement importante. Ça, c'est une expérience dans une région semi-rurale du Sénégal. Nous avons formé 275 prestataires de santé. À la suite de ça, ils ont dépisté plus de 6000 malades et que tout simplement, nous n'avions que 5% de lésions positives. Ceci également, la zone de jonction était entièrement visible dans la majorité des cas. La prise en charge reposait essentiellement sur l'abstention. Nous avons fait la thermoablation dans le cadre d'une stratégie CNT pour 150 malades, ce qui représentait 2,43% des cas. Comme nous l'avons dit, la lésion siégeant essentiellement sur la lèvre antérieure du col, nous n'avons noté aucun effet secondaire et à la longue, ce sont les sages-femmes qui utilisaient. Donc, nous avons utilisé la stratégie du see and treat, screen and treat, voire dépister et traiter. La cytologie cervico-utérine est utilisée habituellement dans les zones urbaines, mais ce n'est pas le test de référence. En cas d'anomalie, comme c'est en zone urbaine, on peut recourir à la colposcopie. Au Sénégal, il y a le test viral HPV qui est disponible avec plusieurs plateformes. Il y a la plateforme Abort, la plateforme GenExpert, la plateforme Care HPV également, la plateforme Cobas, Optima HPV. Mais toutes ces plateformes sont caractérisées par le coût du test viral HPV qui est extrêmement cher. Donc, pour nous, c'est un test inadapté pour l'Afrique, ce qui fait que tout simplement, l'Afrique doit penser à avoir un test beaucoup plus abordable, moins coûteux, beaucoup plus robuste pour avoir le maximum de clients. Ce test viral HPV est extrêmement important, surtout si on peut faire de l'auto-prélèvement pour certains malades et ça permet d'avoir le maximum de clients. cette expérience a été pratiquée dans un centre de santé au Sénégal, au niveau du centre de santé Nabil où la prévalence du virus était à peu près de 12%. Ce sont les papillomavirus 16 et 18 qui étaient prévalents. En cas de test viral HPV, au Sénégal, plusieurs stratégies sont faites. On peut faire de la colposcopie habituellement. C'est ça qui est même recommandé, c'est la colposcopie qui est faite. La cytologie est rarement réalisée et l'inspection visuelle après application d'acide acétique également est rarement réalisée. Quand nous faisons la colposcopie pour test viral HPV positif, chez 8 femmes, la colposcopie est normale. Chez 2 femmes, la colposcopie va retrouver une anomalie. Ça peut être habituellement une transformation atypique de grade 2 dans 4% des cas, une colpite virale dans 10% des cas où on a la coloration inhomogène du col de l'utérus en brun acajou. Comme nous l'avons dit tantôt, toutes ces stratégies doivent être utilisées soit dans le cadre du screen and treat ou bien dans la stratégie screen, diagnostic et treat si le colposcope est disponible. L'Afrique doit également utiliser forcément l'intelligence artificielle. C'est ce que nous faisons, c'est ce que nous avons essayé de faire au Sénégal. Nous avons travaillé sur une application qui nous a permis de classer le col utérien en 4 catégories: col normal, IVA positif, polype et suspicion de cancer de col de l'utérus, où nous avions mobilisé 10 000 images de col de l'utérus. Dans tous les cas, pour éliminer le cancer du col de l'utérus, il faudra penser à la stratégie de Xavier Bosch, HPV Pasteur. Pour les malades qui sont dépistés au test viral HPV lorsqu'ils sont positifs, il faudra évidemment les vacciner. Ça va être une vaccination hors cible, ça va être la vaccination de l'adulte. Ça permet d'une part de freiner la contamination, mais également de lutter contre l'anxiété. En Afrique, il faudra évidemment associer dépistage de la mère et vaccination de la fille. Pour y parvenir, comme je l'ai dit tantôt, il faudra former les gynécologues obstétriciens des trucs, raison pour laquelle à Dakar, nous avons déjà un diplôme universitaire de colposcopie de pathologie cervico-vaginale depuis maintenant 10 ans. Ça, c'est la promotion de cette année qui regroupe plusieurs nationalités. Et chaque année, pour former nos apprenants, nous organisons une caravane de dépistage du cancer du col de l'utérus. L'année passée, nous avons plus de 3000 malades. Sur cette image, vous voyez tout simplement une malade qui avait deux cols qui se regardaient. C'est ce que nous appelons les cols jumelles. Sur ces deux cols, nous avons fait le test viral HPV qui est revenu négatif. Et nos apprenants réalisent régulièrement de la colposcopie. Mesdames, Messieurs, chers amis, chers collègues, nous disons que tout simplement le cancer du col de l'utérus est un cancer viro-induit dont l'histoire naturelle est bien connue. Il constitue encore une tragédie en Afrique du fait du manque d'infrastructures, d'équipements et de ressources humaines qualifiées. Pour son élimination, il faut construire des infrastructures, équiper les centres, former les communautés et renforcer en compétences et en connaissance des prestataires, de tout centre sur un programme de dépistage organisé qui privilégie un test viral HPV disponible, robuste, facile à transporter et peu coûteux. Nous préparons la semaine prochaine ce premier cours international de colposcopie avec la Société américaine de colposcopie et de pathologie cervico-vaginale. Vous êtes invités à cette importante activité. Je vous remercie pour votre aimable attention. Thank you for your attention.
Thank you so much, Omar. Thank you so much for this presentation. But I have one question. Do you have any data on the efficacy of thermal coagulation of the lesions?
Yes, I have that data to thermal coagulation?
Well, for this question, I can say even if you make ablative or excision and treatment, the cure rates are similar, 90%. The problem with the ablation is that you can miss any occult cancer because you just
Yes.
ablate without having any pathological result. For this reason, I think in case that if you have the infrastructure to refer the patient or follow-up of the patient for any type 3 cervix where you cannot see the canal, or for any lesion that you think goes inside the canal, I would rather prefer excision, but not ablation, because there may be an occult cancer coming up in the canal. So, dear friends, we invite you to Senegal Dakar meeting. Also, we have a January by 2026 in January in Cairo, BGICC meeting with Hisham El Ghazi. There will be a colposcopy workshop. There are several questions coming up when you will have the colposcopy workshops and the webinars on HPV. But I can definitely say you that we will organize this with European Federation of Colposcopy, and there is a curriculum that's already being prepared. But you will have a fantastic colposcopy workshop, colposcopy course directed by Vesna Kesic and Michaela Grigore, who is with us today. So please be a little bit patient, and then the big program is coming up. So I think in WhatsApp sections and in many other places, I have answered a great majority of your questions. And now, for me, we can have a break, but I would rather suggest you to continue with the next session. Mario, are you here?
Yes, dear Murat.
How are you, Mario?
My friend, here a wonderful session, very interesting topics. Thank you for your organization and also, my friend. You are great chair of our committee. Thank you.
Thank you. Thank you so much, Mario. I'm